Hi, everyone. My name's Dawn. I'm just going to go through a few things before we get started with the conference. Welcome to the MS at the Frontier and Beyond conference that's happening today. Next slide, please. First off, I just want to go through the agenda with you really quick. We're going to be starting with the welcome by Dr. Yadav, Aging with MS. Then we'll have a break and exhibits, neuroradiology MS, MS research and treatment update, another break with virtual exhibits, and then the Q&A panel will conclude the program where you can email in questions. Next slide, please. So if you have any technical issues that are going on during the program, maybe your audio drops off or anything like that, you can email me, Chris Dawn at OHSU, and I'll route you to our wonderful IT staff that are working today. If you have any questions about the program, again, just email me. My email is also provided in the participant emails that you would have received, as well as here. Next slide, please. So at the conclusion of the program, we'll have a Q&A panel. If you have questions for the speakers that have presented at that time, you can go ahead and email me. And if you have a question for a particular speaker, just note their topic in your email, the subject, if you would please. And we will go ahead and start the Q&A around 12:10 p.m. Pacific time. Next slide, please. And I would like to go ahead and take this time to thank our virtual exhibitors that we have today. We'll have representatives attending and participating today: Biogen, Bristol Myers Squibb, Genentech, Janssen, Novartis, and the National MS Society. So we encourage people to visit these folks during the breaks. They'll have a lot of great information for you. The links are in the YouTube description as well as the exhibit email that was sent out. Next slide, please. If you enter exhibitors, we have a really fun opportunity this year to have your name entered into a drawing. So if you visit one exhibitor, you get your name entered once. If you visit more than one exhibitor, you can have your name entered several times. And you'll receive a code word by visiting the exhibitors. And just after the conference ends, you'll just email me that word. You'll be entered into the drawing. And then on Monday, we will announce who won the drawing. And you can have a chance to win an iPad, earbuds, or a mug. Next slide, please. So without further ado, I'd like to welcome our director of the MS Center, Professor of Neurology at OHSU. She's the director of the fellowship program at OHSU in the Portland VA healthcare system. She's a staff neurologist and researcher at the Portland VA healthcare system and also a faculty. She has research from the Department of Veterans Affairs, National MS Society, NIH, and the PCORI. Her research interests are novel therapies and complementary treatment options for MS, which includes dietary lifestyle changes, vascular risk factors, antioxidants such as lipoic acid and mito-Q, and stem cell transplant. So welcome, Dr. Vijay Shri Yadav.
Thank you, Dawn, for the nice introduction, and welcome everyone from Portland here on the west coast of USA. A very happy Saturday, and I'm really excited to host this program and be the moderator as well for the Q&A sessions at the end. I would like to, can you go to the next slide? I would like to briefly tell you about the MS Center. We have been having this symposium for more than 25 years now, and each year the audience has grown. In fact, after the COVID hit, when we were struggling with how to conduct these programs, this became a big opportunity for us to rather be much more visible to like entire nations. So now we have people who are attending this program from all around the country. In fact, it's international audience that we are hosting today. So I'm very pleased about that. Next slide, please. So briefly about our center, we are a comprehensive MS care center. What you see here is, in addition to the clinical care as a neurologist that we provide to our MS patients, OHSU has a whole variety of other specialty care which is available to our patients. That includes anywhere from infusion therapies. As you know, many of our MS medications are infusions. The drugs which are available to the patients, the OHSU pharmacy has them available in addition to the other specialty pharmacy that these drugs are given through. We work with a variety of subspecialists. The symptoms that patients suffer from, whether it is a urological problem, whether it is an eye problem, whether they have pain issue, whether they have rehab needs, all of those facilities are available at OHSU. We have excellent radiologists, neuroradiologists, and you'll be hearing from one of the key people here who are available for not only diagnosis of MS, but also management of MS as we utilize MRI technology in our management. We have excellent radiologists to help us with patient care. We have access to sleep specialists. We have rheumatologists. We have neuropathologists. Neuropathology are doctors who are they are experts who help us in analyzing very specialized patients where the diagnosis can be challenging. We have access to neuropsychology and psychiatry unit, as well as mental health, as you know, can be a big problem in MS patients. And we are a big proponent of wellness in MS. March Wellness is just one of the examples of why OHSU has invested so much on the overall well-being of any patient, and MS, of course, is at the forefront of that in terms of research and both clinical care. Next slide. Briefly about our center's origin. It was founded in 1983 by Dr. Dennis Baudet. Dr. Ruth Whittam and Dr. Michelle Mass sort of came along, and then they have been kind of the founding figures of the center. Currently, we have more than 1,500 patients each year that we follow in our clinics. We have very strong affiliations with a variety of organizations, one of the key ones being the VA hospital. We are not only providing care for the veterans at the VA hospital in Portland, but also we are part of MS Center of Excellence, which I'll explain a little bit more what that is. We are also partnering with the consortium of MS centers. We are partnering with National MS Society. We'll talk more about that in just a bit. And then we also are part of this Race to Raise MS Center Without Walls organization, which is a nonprofit organization where we have access to one of the kind of top institutions in MS research as well as clinical care, where we are able to easily access and brainstorm ideas with other researchers in this field. Next. So a little bit about the VA-MS Center of Excellence. I know there are veterans who are joining the program today as well, so welcome veterans. I'm also one of the doctors who is part of the MS Centers of Excellence. MS Center of Excellence, there are two centers in the United States, East and West Coast. We are part of the West Coast MS Center of Excellence for the VA, and the Centers of Excellence, their job is to sort of look at the overall care for veterans that the centers can provide, kind of monitor, supervise, and guide. So the clinical care, education and training, using of informatics to enhance the healthcare delivery, as well as enhancing research and development are some of the core values and core goals of the MS Centers of Excellence. Next slide. Most of you know National MS Society. This is sort of indispensable right now for the MS people all around the country. MS Society provides support directly to the patients. This MS Navigator program is an excellent program where not only through the website, but through phone calls and other means, these navigators are available to the MS patients to go through this complex process sometimes, that patients face in their care. MS Society is very big on advocacy, as well as there are many programs which MS Society, in addition to the huge impact it has on research in MS, in advancing research. So the website is extremely accessible. It is very easy to read. So please always, check out the National Society for latest on any advancements, that the field has. Briefly about our center faculty, we are currently 8 faculty who are primarily seeing patients and also doing research. Dr. Dennis Baudet on the right, he is the founder and he's the former director of the center. Dr. Ed Kim, Dr. Jackie Bernard, Dr. Willis Croft, Dr. Elizabeth Silverman, Dr. Lane, they are the key OHSU people who are seeing patients. Dr. Rebecca Spain and Dr. Michelle Cameron, they are primarily at the VA, and they see patients at the VA. Next. We also have a very robust and vibrant fellowship training program. And as part of that, we train the next generation of MS clinician scientists. Currently, we have 4 fellows, and these are neurologists who have completed the neurology training, and now they're specializing in MS and neuroimmunology. Dr. Kayla Martin, Dr. Vicky Chen, Dr. Derek McFall, and Dr. Christopher Holland. Dr. Holland and McFall will be graduating from the fellowship in like just this month, end of this month. And Dr. McFall will be joining the practice in Eugene, and Dr. Holland will be staying on with us to do further research. We have 3 outstanding fellows who will be joining us starting in July, and very happy to be part of the training of these excellent doctors. Next. The center cannot run without the excellent support of our support staff here. Annie Chen is a pharmacist with the center. Christine Perry and Nicole Aschenberner, they are the MA and the LPN respectively, and they really hold the fort together. We have excellent research staff. Emma, Andrea, Allison, Karen, Tatovic, and Sharon, all of them are really making the research, clinical research possible at OHSU MS Center. And we have our fellowship coordinator, Jamie Henry, and Don Christensen, our excellent education coordinator, who's putting this program together and really brings many of the programs that we do for the patients as well as providers. She is the backbone for all of them. So thank you, Don. Next. We are big on MS Center. At the MS Center, we are big on education, whether it is provider education or whether it's patient education. What we are doing today at the Frontier and Beyond is our annual patient program. We used to have a program which was called Brown Bag, which we also used to do at the center in person. That is on hold currently. We used to do a program called On the Horizon, which was also a program, which was a traveling program. That is on the hold currently as well, but we hope we can bring some of these patients program, which are more frequent to our audience throughout the state and throughout the nation now. We have done COVID education throughout this pandemic, starting in 2020 when it first started. We have done 3 programs, and all of them are available as archived on our website. If anybody wants to review them, these are excellent reviews for anybody and in general. And our newsletters, which are going annually, as well as we started a research newsletter recently, which are giving updates on what we are doing on a regular basis. The training program, I briefly mentioned about the current fellows. As part of that, we are very proud to be on the national stage. We are able to help educate the fellows at the national level, where we have put together our these webinar series for the providers, as well as doing this annual MS and CNS Neuroimmunology Symposium to educate the healthcare professionals. Next. While the slides here you see is kind of small in font, I can only tell you that we are really big on clinical research. As I mentioned, several of our faculty are heavily involved in clinical research. Wellness has been a common theme for a long time. We're also big on trying to develop novel therapies for MS. One of example would be a drug which is similar to thyroid hormone and could have a very big impact on remyelination in MS. That's something which was developed at OHSU. So the whole variety of things that we do here, I feel very proud to be a part of that, as well as hope that you will all support by taking part in these research studies also. Next. In addition to the clinical research, we are also big on basic science research. Our scientists, the basic scientists who have their labs here, they are really doing the work looking at the basics of at the molecular level or at the very fundamental level, how the MS process occurs and what can be done to improve the process, whether it is myelin formation, remyelination, exon regeneration, or the overall function of the nervous system. How can that be enhanced by studying the basics of neurosciences? That is conducted at the OHSU, and I'm extremely proud of our team here. Imaging, we are really big on that. You must have heard about the monkey research, which was done at the Primate Center by Dr. Wong, which was hopefully going to be discovering possibly a novel virus, which may have connection to the MS pathogenesis, and also having a whole variety of other programs available at OHSU, which enhances our research portfolio. Next. So with that, I would just summarize that our mission is to help people with MS lead the best possible quality of life by providing comprehensive patient care services, community and physician education opportunities, and to be a world leader in research in our quest to find cure for MS. Next. So I would now like to welcome all the people who are attending this program from 45 states, 4 countries, and the veterans welcome. And I would now like to introduce our first speaker that I'm really excited about, who is joining us from Romania, from Europe. So thank you, Dr. Weinstock-Gutman. Dr. Weinstock-Gutman, she's a professor of neurology and State University of New York Distinguished Professor at Jacobs School of Medicine and Biomedical Science in Buffalo, New York. She serves as the director of the Jacobs MS Center for Treatment and Research, as well as the Pediatric MS Center at the University of Buffalo. She also serves as the executive director of the New York State Multiple Sclerosis Consortium. She did her medical school from University of Bucharest, did her neurology residency from Tel Aviv University, did fellowship in MS from the Mellon Center for MS Treatment and Research at Cleveland. And her research interests include, in fact, I feel like she has been my mentor in guiding the research, especially looking at the role of environmental factors in MS. For example, like an effect of vascular disease or role of diet in MS, all of that. I've been personally inspired by her work. So, I mean, I'm really looking forward for her talk. So without further ado, I would like to invite you, Dr. Weinstock-Gutman, to educate our patients as well. Welcome. Can you unmute?
You better. So I'm very lucky when I started my MS journey as a researcher and a clinician, there were no medications. So I was very lucky. I was at the time when everything started, and we hoped it will get much better. I was involved also in the pediatric MS that just started, and at the moment we have involved a lot of pediatric neurologists, and pediatric MS is now getting better and better known in diagnosis, and we hope that we made a difference. And now it's aging, myself as well as my patient. I became very interested in aging in MS. And this is very important. Next slide is because the number of MS aging is increasing. This is my outline. We're looking on the epidemiology, meaning the number of MS patients aging that is increasingly all over the world. We'll talk about treatment, the limits that we have, the problems that most of the medication we have today are actually evaluated in studies without involving aging population, and the way how to measure actually the benefit of different medication in aging population that present differently. So next slide. But as we know, 60 and aging like fine wine. So hopefully everything will be better after 60. Next one. So there is a program, probably you heard about, the so-called Atlas of MS, that are trying to identify the number of MS all over the world. And this is increasing in general, so all number of MS. So back in 2008, we were known about 2.1 million. 2013 went up to 2.3, and the most recent in 2020 went up to 2.8. And it appears that if we know to diagnose, MS is now existing all over the world. There's no more areas we thought that are protected. We, as possibility the diagnosis exists, started to see again with different frequency, but MS is seen all over the world. And still women are much more affected than men. Next. What it identified recently, and in the left side, we can see here the data on the prevalence, meaning the number of MS patients in US based on the age. And what was found that the highest peak is actually between 55 and 65. And that is not only in US, is seen in Norway, Denmark, all the world. Here we have down here, actually also in Canada, and you can see it's very small here, unfortunately, but it says in 80s, and when the peak was around 30s, you go and moving for 40s, and mostly between 90s, it's going again, increasing between highest between 55 and 65. Next one. So the number is increasing of MS patient aging, along with all general aging population. We know how to treat comorbidities. We'll talk a bit later because aging is associated with comorbidities. We know how to treat them. The patients are aging, and so the life expectancy increasing. So all population, but also MS patients. Clearly, we have to include a benefit from the disease-modifying therapy started much earlier on, and having a benefit on increasing the life expectancy. However, as I mentioned before, and I'll repeat this myself, it's majority of the studies on all the medication available today are majority on younger population and not including people over 55. Next. So why it's different? Aging population is primarily, besides having additional comorbidities that I said we'll talk a little bit later, the immune system is different. As we all know, we do have two different immune cells. The innate immune, that is the first line of fighting against viruses and also protecting about cancer, is actually remaining pretty much the same. But the acquired immune system that we know about, the T cells and the B cells, are different and decreasing. And it's what we're calling a decrease in their activity. It's changing. But in the same time, there is a chronic inflammation. We're calling this inflammaging, that is possibly related, it's considered. I know that there will be different talks about EBV and CMV, and it is a certain consideration that the chronic aging diseases, including cardiovascular, may be related with this chronic herpes infection, both of them, EBV and CMV. Next one. So the immunosenescence, so the primarily so-called decreasing effectiveness of the immune system, it will be, and it is, associated with increased risk for infections. Will be a reduced response to vaccine. This is also, I'm not talking about the COVID, I will talk about all the other vaccines, including the flu vaccine that we know that is so important, giving in double dosage for people over 60s. But in the same time, as I said, with this inflammation, there is a higher risk for autoimmune diseases that are related with abnormal antibodies mostly. And we know, and that we're fearing, is the neurodegenerative diseases of aging that we know, it's Alzheimer, Parkinson's disease, and we know that it's increasing with age, and we may expect to see this also in MS patients, although we'll talk about later, and I don't want to get into this, we do feel that Alzheimer in MS patients is less frequent. Let's go. Next. So that's a kind of a cartoon to show you about this acquired immune system that is different. As I said, on the B cells, the production of the immunoglobulins, meaning the antibodies, is less, maybe also abnormal, and the effectiveness of the T cells, the response is different, and maybe even moving to a more pro-inflammatory, with so-called in direction of the Th17. So let's next. So are actually MS patients aging faster? we do know that there is a clear difference between what we call in chronological aging, meaning the age 60, 70, 80, and the biological age. We have people on their 90s that are very, very good maintaining their activities, physical and mental. And we have patients in their 60s, or actually every person's 60s that are much more frail. One of the elements that can be correlated with the it was chronological primarily, but also with biological, is that the telomeres, that is the end of the chromosome, that is our DNA information, that with activity, and including the aging, may become shorter. There is also an enzyme that's trying to pick it up and fix it. It's called telomerase. That activity is decreased. There were studies looking for kind of a simple way to try to measure this telomere length in the blood cells from MS patient compared with matched healthy control, and found that they are shorter. And there was a study also comparing the telomere lengths with the disability. We know, and disability as we're using most, as you know, the EDSS, the so-called gold standard measure in MS. And it was found that a shorter one is associated with more increased disability, so higher EDSS, as well as with more brain atrophy. It didn't change so much for the other next few years, 10 years that they found, but it's clearly more in the baseline they identified this clear correlation. And it was more associated with moving towards secondary progressive. Let's go next. However, what we know from the small number of the patients involved in clinical trials, but also from our what we're calling observational studies. So we have patients that are very, I'm sure that also in Portland, they are very much open to participate in different studies, not only treatments, but also measurements. And what is found is that with age, actually the risk for relapse is decreasing. So that's a good thing. So most of the relapses are usually seen between 30s, 40s. Our kids, very young, are having much higher risk of inflammation, and all is going along with the hormones. So in one side, it's good with aging that the risk for relapse is lower. It was actually a study looking to count on this and identify that every 5 years out of the first time that you have the first symptoms, within 5 years, every 5 years, you have a decrease of 17% of the risk to have a relapse. Next one. Along with this, because relapses are going along with new GAD enhancing lesion, we see less active in GAD lesions in aging population. But as already mentioned, if we're looking on the studies that we know most of it, here we have the CombiRx, very early, first 5 years of treatment. This compared the Avonex Copaxone combination versus the other 3 studies that including patients with progressive disease, but again, most of them were around 40s, very few in the 60s. With all this, when we compare, we do see less enhancing lesion in aging population. Next. However, we have to know that the repair processes, if something happened, it's less beneficial, less effective with aging. The remyelination is decreasing with aging. So if something happened, if there is no protection for preventing new lesion or new relapse, the possibility, as I said, of repair and recovery is less effective with aging. Next. This is a study that we did in Buffalo. We are very lucky that we have a great brain analysis center. And what we wanted to compare is MS versus different diseases, as I mentioned, usually appearing in aging population. And that's, we had Parkinson, Alzheimer, and the so-called mild cognitive impairment, something that people may have cognitive issues, but are not at a degree as Alzheimer. We have around 180 patients healthy controls, and MS also around hundreds, and the rest were around 40s. So what we found is that the whole brain volume in MS was a bit lower than all the others, but clearly all of the other neurodegenerative diseases were lower than the healthy controls. When we differentiate between the white matter versus the gray matter, MS was the most affected, lower as the white matter, where we know that the most the lesions are, but we know also the gray matter is affected, but the lowest was actually in Alzheimer's disease and not in MS, as compared also with healthy controls and in between. Next. So we have a lot of medication. Every year too, we have another one, different mechanism of action. But as already mentioned, there are very few aging people over 55 involved in this study. Even in the progressive study, where the so-called inclusion criteria was up to 60 or 65, the median age was 46. Let's go next. So there were recent, repeated, but also this was a few years ago, analysis on the existing FDA-approved medication in general for based on age. And what's identified is that actually the effectiveness of this medication, FDA approved today, are less effective in preventing the progression, the disease progression in aging population over 50. However, it was a similar benefit on preventing lesions or relapses. So the consideration of aging as a primary risk for progression is there. The disease is changing from an immunological standpoint, from an immune system of the patient itself. So we clearly need different intervention. And we have to know what to recommend to our patient. Next. So it's not only discussing about the effectiveness. We have to keep in mind also the safety. Most of the newer medication, the so-called we call it depleting, most there's probably also you know about the B-cell depleting therapy, the B-cell therapy. It's one of the most effective therapies. Also, the only one showed benefit on the primary progressive patients. What we have to know is that, and already presented before, is that with aging, we have a decrease in immunoglobulins. If we starting the B-cell therapy, the immunoglobulins are going down too, even more. So you have a much more decrease if you start from a lower level. And this was associated, especially for the B-cell therapy, with increased infections. And unfortunately, infection and so on, with associated even mortality. As you all know about PML, progressive multifocal leukoencephalopathy, primarily related to Tysabri, was also shown more frequent in people over 50. And also the outcome for people that develop PML was worse in aging population. Let's go back. Next. In the same time, every one of us over 50s and 60s, we know that the risk for cancer is higher. Again, because the immune system is coming down. If you add on an additional immunosuppressive therapy, the risk is even higher. So that is very important to keep in mind, efficacy and safety when we discussing starting or continuing a disease-modifying therapy. In the right side, I have here also with regard one of other treatment, the DMF. This also showed higher risk for decreasing the absolute lymphocytes because they're usually starting from a lower, usually it's a decrease of 30%. And after 50, we have a higher chance to decrease. And again, we know that this is a concern that may be associated with PML. And also when we stop, the recovery time is longer for aging population. Next one. So I only want to introduce very shortly our big registry that my mentor, Dr. Jacob, started. This was back in first 1996, including 13 MS centers with primary home in Buffalo. And we try and continue, as we also Edap said before, we need a lot of funding to keep going. And we have around 10,000 patients enrolled. And patients, we are trying to update yearly our assessment with the EDSS, with a 25-foot walk, with different objective measures. But we do have also a patient-reported outcome we'll talk about. It's very simple, one page that the patient's putting in, and you're probably doing a lot of the study with Dr. Dav, and it's very important. It's very, very important. I'll show you how important this later on some of our data. And I will show you a few studies only out of this registry. And this, again, data that we have, although we follow this patient prospectively, all the data that we obtain is retrospective. We're calling this observational studies. They are not perfect, the same as what we're calling randomized study. One patient gets something, and it's so-called very, very similar. But there are certain statistical ways to try to control on it and to do have really a real life data, because as we know, patients in study are younger, they don't have comorbidities, they are a little bit cherry pick. Let's go next. So, as you probably all know, is a discussion of this discontinuing medication after all the information I gave you on patients over 55. So we looked on our consortium data, we looked on around 250 patients that we have the data on their disability, on their status, physical, for 2 years before stopping and 2 years after stopping. We don't have the exact reason for why they stopped. Most of them are financially, or they were tired of the injection. Most were the injectable. 40% of these patients were over 55. And we primarily concentrated on patients that were stable before discontinuing, and they were 70%. So what we found is actually that 30% of these patients, they were stable before discontinuing. Actually, they progressed. And there was no difference between the progressors that were younger or older than 55. We could not yet pick up exactly all the variable and the demographics and the specifics on the patient that progressed versus not progressed when they were before stable. So this, brought to the consideration that all this observation study, or even a larger study from the so-called MS-based, that is really international, very large European and Australian, where there are also 2 centers from Europe, from US, we also part of it, kind of. This was a study that to try to prove scientifically, should we really discontinue, is it worth to discontinue the medication in patients over 55, looking if they were stable as related to relapses and MRI lesion within the previous 5 years. And this data was recently presented preliminary. And again, comparison between around 150 and 150 patients continuing versus discontinuing the medication. And I won't go more on the little bit difficult to understand the outcome measure, the so-called non-inferiority, where I wanted to show that they are the same. And the final data is actually they were not the same, that the patients that discontinue had a higher risk for more lesions. Possible relapses, they were not perfectly, they were pretty similar on the disability as measured with our EDSS, although again, not everyone finished 2 years, it was a short time. Altogether, when they provided again, is only preliminary data. There was presented only, Dr. Yadav was there too, on our CMSC, only 7% of total patients may be really worsen. In the end, the discussion on the continuing medication versus discontinuing versus actually what we're calling a de-escalation or changing, switching, is really based on discussion between your physician and your own consideration, putting on plus and minuses. But at the moment, what we have is that discontinuing, even if you're stable, it's not really 100% that you stay. So even if you're aging, even if you have a lower risk of relapses, even if you have a low risk of new lesion. Next. So about aging, many patients do have a lot of medication. It's the medication that are coming from the comorbidities, from all the other requirement, plus what we're giving to take care of spasticity, to take care of pain, to take care of bladder problems. So more medication, they may interact in between, they may have more, side effects, or dizziness, or balance, and we know that it may increase the risk for falls. So that's important to really look on it and see if really all the medication are absolutely necessary. And sure enough, adding on, and I know that you are very much looking for different supplements and so on, very important to update your doctor about everything you're taking in each time you're coming to your visit. Next. And going to comorbidities. As Dr. Idav said, I was very interested on this from a long time, primarily also with your centers with Dr. Swang that started me first one when I had a first study of really very hard Swang diet, but as an add-on to medication. And we did show at that time, I didn't have enough money. I was at the Cleveland Clinic first time, and I used very early on as a patient-reported outcome as a database. And indeed, we showed that, fish oil was a little bit better as an added on, but a very low fat to our patient. Did decrease the relapses and inflammation, but it was too low. The other one was what we're calling American Heart Association diet, kind of a normal fat, meaning low fat but healthy fat, and adding on olive oil. Unfortunately, we know how olive oil is so good, but that was the only placebo that company that gave me the fish oil was able to give. So this patient did good. Everyone lost weight, but they were less fatigued. So we have to work on it. Not to go too low in fat is not good either. Anyway, so talking about the comorbidities, as we see in the left side, we know that the cardiovascular comorbidity, meaning hypertension and cholesterol, hyperlipidemia, and diabetes, it's going up with age. As you see here, over 60s is almost 50%, and this could be less in the earlier. And it was also found from this NARCOMS data, from patients' reported data, that the primary comorbidities seen in MS actually is increasing at kind of a time, although they were existing also before, as a premonitory maybe information, including anxiety, depression, but also hyperlipidemia, hypertension, increasing at the time of the diagnosis. Next. This was a more recent data obtained from 10 centers that are using this MS-PET, meaning digital electronic data entry, and compared with what is the data from the so-called National Health Nutrition Examination Survey. And they found for people over 60 that MS patients that were including in this 10 center were 6 from US and from Europe, rest, that to have actually more depression than the general population over 60. Next. Yeah, keep going. It's keep going. Okay, yeah, stay there. So also from this NARCOMS data from identified that presence of comorbidities, especially more than one, even up to 3, is associated with increased disability. What I'm saying to my patient, if the patient have blood pressure, and again, very to know that the maximum we're giving today is 130 on 80. 140 on 90 is no more good. So we have to control comorbidities. That's for all of us. But if you have MS on top of it, you have to take care even more of it. In addition, we do learn about the so-called late onset MS. It's rare, it's 4 or 5%, meaning onset after 50. And many patients may have delayed diagnosis because they have hypertension or diabetes, and the first event may be actually related to their comorbidity. So that is very well important to know. And it's also important to know all my patients and so on saying, be sure that you have, if any symptom comes up, to be sure that you don't have only the label of MS, that something else can happen, especially if you already have hyperlipidemia, hypertension, or diabetes. Everything else can come up. Again, treat this very, very important, even more important because you have MS. Let's go next. So on the cholesterol, I was very, very much interested. How I started with this? Actually, I was started because I was looking much more for the HDL. I was learning, over 10 years ago, that patients with high HDL, it's actually genetic. That when they did studies on the octogenaries and centenaries, the over 80s and 100s, most of them had high HDL, and they were actually giving also the first generation have a much better HDL. So first of all, we did a small study and we saw that higher HDL was associated with low EDSS, and then said, hey, you have to see all the LDL, all the HDL, all the triglycerides. And we have, again, retrospective data from our clinic for 2 years. And what we found that the higher LDL and higher triglycerides were associated with increased EDSS after 2 years and also with more MRI atrophy. So we kept going from there. We had with my collaborators and identifying not only the cholesterol, not only the LDL, the correlation HDL, the oxysteroids. So the lipids have clearly very much interference with MS progression. We found actually even very early on the so-called the CIS treated that higher LDL was associated with more lesion. So it's very important to control the lipids. Next one. That was another study. Again, the CombiRx I already mentioned. This was young people, meaning people that are not all young, but within 5 years of the diagnosis, that also found in the retrospective data from thousands of patients that having dyslipidemia, meaning high cholesterol, high LDL, and low HDL, that have a 30%, third more higher risk to have more relapses, more MRI, and more progression. So we have to keep in mind that we have to keep the cholesterol on bay. Now we had another study. We had a large, the so-called CTVD study that we're looking for the comorbidities and their impact on MS. And we have over 500 MS patients. We have controls. We had also other diseases, but that's what we primarily, concentrated on. And we looked on patient presence of hypertension, presence of heart disease. And we also, they filled in, we are very grateful for all the patients participated, a lot of questionnaires on their diet, on their sleep, on their alcohol, on the smoking. So all this worst lifestyles. So what we found is that the patients with heart disease, as well as hypercholesterolemia, have actually more atrophy when comparing for everything, their gender, their disease duration, and even if treated or not treated, the time of the treatment. And the same for the patients based on their information on their lifestyle. So worse lifestyle, so again, having not exercising, not sleeping well, not eating well, all this were associated with more lesion and more atrophy. Let's go next. So that's the study that is here is actually a STEM study that was done for general comorbidity, or not MS, clearly showing benefit on preventing lesions while treating better the comorbidities. And there are a lot of prospects on an application of the grants trying to see how to do this. And it's all the time we cannot not to give a perfect treatment for comorbidity on our MS patient and compare with something that's very good. So altogether, what you have to take in mind, especially anyone that have comorbidities, especially cardiovascular, hypertension, hyperlipidemia, do take, and diabetes, your to have this very well controlled. There were also, as mentioned, also the depression that could be also seen, especially in an aging population. Treating this also showing benefit on general quality of life. And we know that there's ongoing study of statins in UK for patients with secondary progressive. Again, statins are very different way how to help. They're not only decreasing the cholesterol, but they have an additional benefit on anti-inflammatory and so on. So the benefit of statin may be more than only effect on their cholesterol. And the interesting fact that also we don't really have, and we should, is actually the benefit of the medication are used for treating these comorbidities. And one of them is metformin. Metformin, the cheapest, usually what is considered the first line that you have to treat diabetes. Not many patients can actually tolerate this. But metformin was shown, and also the pioglitazone is another one, the anti-diabetic, showed in a younger patient with active disease. They were in injectable, adding on, and they did not have diabetes, that their MRI improved as related to new lesion. But metformin is showing a lot of neuro benefit if you can tolerate, showing really remyelinating properties. There are 2 studies now on remyelination, including one in pediatric MS, with using metformin as a possible remyelinating agent. Next. Sure enough, smoking. Yeah, smoking is bad. As we all know about what are the risk factor, and we know now we know about ABV, we know about smoking, we know about vitamin D. Smoking is one that is primarily clearly shown that is not only a factor of risk, it's also a factor that clearly interfering with disease progression, with changing from relapsing to secondary progressive. Anytime you can stop and is showing the benefit from it. How exactly it's interfering? That's we clearly not sure about blood-brain barrier, changing the immune system even on the lungs and so on. Clearly, stop smoking. And I have a lot of very long discussion with my young patients that really not only for them, but also go away from friends that smoking. Next. Bones. Bones are very important. I was very much also involved for a few years on bones. We showed that osteoporosis is showing in MS even earlier on. Sure enough, postmenopausal is very well known. It's much more than the general population, even in men, that we know that is only after 70. It's mostly related to limited mobility. However, we did have study and showing not only ours that the decreased bone density is also maybe not osteoporosis, but even osteopenia, is actually seen also in MS patients fully ambulatory. And there was no relation to really steroids. There's much more concern on continuous low dose oral steroids versus, high doses giving in between and in the interval. Again, I'm not going too much on this, on the steroids and so on. But there was a old study over 10 years ago, 15 years ago in Italy from my colleague Dr. Zivalinov in Italy, where they didn't have yet medication for MS. And they gave steroids initially every 3 years, and after then every 3 months, and after 4 months, there was for a few years. Actually for first year and 2 years, and compared with the one they had only steroids as needed a relapse. At that time, they didn't have any DMTs. And what they found actually that the patients that had repeated every 8 weeks after, then every 3 weeks and every 3 months and every 4 months, having even more steroids, they were able to walk better, and they had actually less bone. Again, have to keep in mind the concern of the steroids on bones, but actually we have to, most important is to be able to walk and to exercise. In addition, we have to figure out other interference with the bone. In MS, the bone is a live tissue. It's forming and reabsorbing. And the problem with aging, the reabsorption is more. Most of our medication we have today is decreasing the reabsorption. That's also an important fact that we're starting to know in osteoporosis that maybe too long time on it may not be healthy. We may take a break and not to maintain an old bone there. Let's go next. So cancer, yeah, over 60, I said we are associated with increased risk for cancer. Interestingly enough, also from our actually recent, we published in 16, I believe, data from our consortium looking for cancer. Again, it was cancer based on patient-reported data and compared with the risk for cancer from New York. So this was from New York MS patients in New York area. We controlled on age, and actually we did show a lower risk. And that is what we had all along. It started to come up now that the number of cancers starting to be higher in MS patient, maybe even higher than control that's showing primarily from administrative databases, Canada and so on. There are other registries that do not support this. There are two issues what's happening today. We have increase in age population, as already saying, cancer may go up, and we have, as mentioned, much stronger medication, much immunosuppressive that may increase the risk. So we have to be aware about it, and we have to follow all the recommendation as all the general population is. Mammogram every year, a check for the GYN, colonoscopy every 5 years. So all the preventive issues and the recommendation for all the population have to be done also in MS patients, and maybe even more and earlier. Next. Memory. Memory is, as we call it, cognitive issues are a concern. We do have with very specific testing identify certain concerns, what we're calling on processing speed, multitasking, and could be even earlier on. It's getting worse with the disease and with aging. It's probably all of us. We do have specific testing. That is what is recommended to be done, maybe to have a baseline at the diagnosis in every year. I don't think we're really, the CMSC and all this thing every year, I don't think everyone wants to have it every year. Maybe, the short 90 seconds, the SDMT could be done yearly. Usually we're going every 2 or 3 years. But it's very important to know that we have to monitor this. Now, I don't know if you know how long it lasted. The first cognitive testing done in the study, in Dr. Jacobs' Avonic study, was 6 hours. Only 60% of patients were able, even with first treatment that were aware and participating in the study, to go through this 6 hours on patients with MS, with fatigue. So Dr. Benedict, we're very proud he's the director of our neurocognitive and behavioral clinic. With other specialists, went down to 90 minutes. So from 6 hours to 90 minutes, so the so-called MACFIMS, limited the most specific testing batteries, it's called, for MS. Next one. So 90 minutes better. They have even shorter, the so-called BICAM. However, for aging, we need additional batteries. As I said, for MS, we logged on, and most of the issues are related, and what we found is the deep brain grade, the thalamus, the connection, and less what is seen on the peripheral, on the really cortical, on naming, that we see this with aging. So what we've started now, very much interested, as I said, in our research on aging, to add on certain batteries that are necessary for aging population, again, and compare with what is considered normal aging. And as I said, what we found is more on the fluency, verbal fluency and so on, different than the processing speed, the timing that is primarily seen in MS. The processing speed is also going down with age anyway. We're saying that even after 20, even 40s, you can see differences in general. An MS patient can be a little bit more faster. What we've also found is the rate of decline. It's slow. It's slow also in early, and the rate of decline even on aging is remaining almost the same. When we do see a fast decline, then we have to think about something else. So not MS, but other disease, for or other consideration of including the possibility of what we call neurodegeneration, the Alzheimer. As mentioned, the number of Alzheimer patients and also very few. We have more patients now aging and maybe a concern. But as mentioned before, there are certain considerations. We'll see if I will be proven that MS and maybe medication, maybe the change on the glial cell that we're so much, looking for as second step, secondary progressive, primary progressive, and aging, when the disease is much more confined within the brain, the so-called compartmentalization. We need to think about what's changed with age, what's changed in MS, and including, as mentioned, amyloid, and it seems that MS have less. So we'll see if I can still prove this further on, if the MS itself and the medication are the ones that may prevent eventually Alzheimer's in our patients. But we have to check. We have to check, and as I said, the batteries for aging population should be more extensive than the battery that are now recommended for MS. Let's go next. So we know they have problem with aging. That's not only memory and associated infection, so on, but it's also physical. Let's go next. So yeah, getting up from chair is a problem, and it's getting worse with aging, and not only MS. So don't let aging go down because it's too hard to get up. Next, go back. Next slide. So we thought about, you probably heard about, and also the rehabilitation, so on, the rehabilitation physician and practitioner are very, very important. And okay, you're still there?
Yes.
Okay, something was, I don't know, on my computer. Anyway, no, go back. Okay. So what is very well known is the time up and go, when the patient is getting up, moving around, and for 5 meters and coming back. And this is much used in the rehabilitation. This, we took the extended time up and go. It's actually from VA that was evaluated for patients and related to fall, aging population. So as we see that in our patient, especially aging, right, but also more with a certain disability, have a difficulty in getting up. So you start to measure from a moment the patient from sitting, getting up, gait initiation. Going here is the 6 meter, but with this two, it's exactly 8 meters as the 25-foot walk. The moving around, we know that it's a problem. It's a problem here, it's a problem here, also with the time, and also getting back and sitting back. So that is very important to all these elements for physical therapists to understand where is the problem and give the exercise best to improve balance. And as I said, switching direction and improving the strength and the possibility to get up. So what we found, we initially did two groups of patients that we've evaluated within 2 weeks, or a week or two, between 1 and 2 weeks twice. We had 2 investigators in our center, and the other was the center, as you know, we have about Sue Bennett rehab, and we miss her a lot. So what we found is actually that this ETUG, extended time up and go, change of 15% it's actually what we're calling a clinical meaningful change. The same as what you use probably with 25-foot walk. You can have a good day or a bad day. What we know already, a lot of data, the 20% change is a meaningful change. It's not only a good day or a bad day or a number for statistics. The same, we've proven that the 15% change on extended time up and go on total, but we could do also much more on each element together, but we didn't do it yet. And additional, what we found, we evaluated around 200 patients after 2 years and having that ETUG at the time. And after 2 years, we had all EDSS in the same time and 25-foot walk. The correlation between all these 3 ambulatory elements were very good. However, after 2 years, there are more patients that worsen on ETUG than the 25-foot walk. And ETUG was a better predictor for EDSS worsening than the 25-foot walk. Sure, we need more data and more for it takes longer time, but could be much more. We used multiple agents on within this, and we have to know exactly what it means, the time, the period. But this would feel that it's much more important for their own. Okay, let's go. I understand that we are running out of time, and I will finish with only listening to patients, the patient-reported data. And as mentioned on our consortium, we do have this patient-reported data. Next, I understand I'm too long. So we had 340 patients, mean age 67. We followed it for 6 years. And what we found after these 6 years that 44% of them were stable and 55% were actually, based on our EDSS, were progressive. Next. And sure enough, what we found is actually, even in our group of patients that progressed or stable, actually there was a significant worsening based on the patient-reported data on getting up from sofa, climbing stairs, difficulty driving, and bowel incontinence, and there was a similar number of patients that worsened in our progressive versus stable. So clearly, we are limited in our assessment. We need patient-reported data, but eventually to have more, objective measure to support any change, especially in aging population. Next. Yeah, so the healthy aging we need, so I think many people are learning about their wellness, what we do in diet, interaction, exercise, genius. Sure enough, you have to have a purpose in life. Next. Treating, exercising, active exercising can take care of depression, even maybe better than all the medication and counseling. Next. And sleeping very good. No, it's most of the reason for fatigue is it's sleeping issue. There is really information, scientific information. Its sleep is eliminated the toxics, and including even amyloid. So a good sleep is very important. Next. Challenge yourself. Don't stay on your own, box. You have to challenge yourself and try to also your mind and learn new things. Next. Exercise. Next. Even in older population, we see new plasticity and new connection. Next. This is the calorie restriction we know about that can be beneficial with intermittent, all kind of different diets and calorie restriction. It was associated in animal models with repair and remyelination. Next. This is the parabiosis theories with that, combining the circulation between the young and the pup and the old one, clearly showing that the help in repair. So there is something in youngs that it's a protein or more that is floating around. It was not yet identified. We did consider a few of them before, and may be beneficial for older population. We're not there, and I heard on the West Coast or clinics that giving plasma from young ones. Don't go there. Let's go. But we'll figure out what the young people have and try to get this for aging. Next. So general, we have to know about the comorbidities in aging. We have to take care of them. Don't undermine. And next, that's it. And we have to know better about aging and involving their own studies. And I will finish with my people. Last one. Next one. That is my clinical people and the MRI Analysis Center, Dr. Benedict, our neurocognitive testing, our lab, Dr. Ramanathan, neuroophthalmology, and Penny Pennington is the program director for our development program director and patient advocate. She's amazing and very much helping us. Thank you so much.
Thank you, Dr. Gutman. Thank you for such a nice overview. And I'm sorry, the time was really I wish
absolutely
like 4 hours or longer.
Yeah, if for later you have other question again, I have to go.
Yes.
Yeah, more
Thank you again.
Any specific question that you feel that are more I will try to do it. If
Well, thank you so much, especially, because you are so far away and a little bit of a rough time also. So our wishes to you,
Thank
to
you
your
so
family
much.
as well,
Thank you.
and safe
We'll fight
travels.
for aging. Yeah.
Yes, yes, yeah. Thank you.
Okay. Take care.
And
Bye-bye.
bye. Thank you. And I think for the audience, what we will do, we'll probably push the break for another 10 minutes. So I think I'll let Dawn come in and then explain how this is going to go till we, go to the next speaker. Dawn?
Hi. So yeah, so everyone can go ahead and take a stretch, grab a snack, have a break. We encourage people to visit the exhibitors. We have representatives here ready to talk and answer questions and get information. We have Biogen, Bristol Myers Squibb, Genentech, Janssen, Novartis, and National MS Society. The exhibit links are in the YouTube description. You can go to show more in the YouTube description, and then also in the exhibit email that went out. We're actually going to adjust the time a little bit and start with Dr. Pedersen's talk at 10:30 for the neuroradiology and MS. So we look forward to seeing you back at 10:30.
Welcome back, everybody. It's 10:30, so I would like to now move on to the next segment of our program today. And are we ready to move on to the next slide?
Yes, can I just mention something? I know there were some issues with some of the exhibitor links, and we're trying to get that resolved for the next break. So I apologize for that.
So Dawn, should we move on with the talk, or should we just
You can move on with the talk, and we'll get it, make sure everything is resolved for the next time.
Okay, all right.
Yeah, thank you.
Sorry for that technical glitch there. In the next segment, I'm really pleased to invite Dr. David Patterson for our talk on the radiology or neuroradiology in MS. Dr. Patterson, he's an associate professor of neuroradiology at OHSU. He's the medical director of MRI at OHSU and also director of the functional MRI at OHSU. He has Anne G. Osborne ASNR International Outreach Professorship and was recently selected to serve in Ethiopia for that. He also oversees radiology residency exchange program with the Siraj Hospital in Bangkok, Thailand. Dr. Patterson did his medical schooling from Michigan State University, did residency and fellowship in diagnostic radiology and clinical radiology at OHSU, and his research interests include adapting the latest MRI technology for clinical use, pediatric imaging, epilepsy imaging, and MR imaging of the fetal CNS. And Dr. Patterson, he will be talking about many issues about diagnostics with imaging in MS. Dr. Patterson.
Yeah, thank you, Dr. Yadav. Appreciate it. I'm going to share my screen here. All right, hopefully everyone can see this. Hey, I'm David Patterson, and I'm an associate professor of radiology at Oregon Health Science University in Portland, Oregon. So here's a little bit about what I do. So I have no financial disclosures relevant. So I'm a neuroradiologist, so I spend most of my days looking at images of the brain and spine, CT images and MRI images, not just for multiple sclerosis, but for every type of neurological disease that we image. I do some image-guided procedures, and I do teaching, a lot of teaching and a little bit of research. I'm also heavily involved with our MRI department and developing new technologies for MRI. All right, so yeah, apologies for the very busy slide here. It's an important slide because these are all the learning objectives that I hope everyone can walk away with today. So I'll be talking a lot about just kind of basic neuroanatomy. And my goal with this is I'm hoping that people can be able to, if they get a hold of their radiology reports, after an MRI scan, that they'll be able to make better sense of what is being talked about in the report and the key things to look for. So some of that has to do with anatomy, some of that has to do with the lingo we use in radiology to describe different findings. And then I'll talk about some MS specific stuff, of course. So starting with the neuroanatomy, multiple sclerosis is a disease of the central nervous system, and the central nervous system is composed of two things, the brain and the spinal cord. The central nervous system tissues are kind of divided broadly into two types. There's gray matter that on autopsy looks gray, and white matter, which on autopsy or specimens looks white. And multiple sclerosis is a disease of white matter primarily, but we also know it's a gray matter disease too. So with MRI, there's many different types of scans that we perform during a single MRI session on a person. For multiple sclerosis, the FLAIR images and T1 images are usually the most important for diagnosis. So we'll be focusing mostly on those. I'll talk a little bit about intravenous gadolinium contrast that's sometimes used with MRI scans and how it's safe, and talk about a little bit about gadolinium deposition in the brain and soft tissues. We'll talk some basics of multiple sclerosis, how it's destruction of the wire insulation, which is like the myelin of axons, And we'll see what that looks like on imaging, and how the diagnosis of multiple sclerosis is made and how imaging is a key component of that. And then we'll be talking about how to decipher the MRI report, like the radiologist report that you may see, and how the primary goal for most multiple sclerosis scans is that we're looking for new multiple sclerosis lesions in the central nervous system and potentially lesions that are so-called enhancing, which is when they get bright after we give intravenous contrast material. And then, yeah, lesions can occur anywhere in the CNS, but only a few locations are important for the diagnosis of multiple sclerosis. And we'll see how artificial intelligence is starting to be used in imaging of multiple sclerosis, as it's being used in all facets of science, and how it has the potential to help with diagnosis. And then I'll just touch on some research. I'm not going to come anywhere near with what Dr. Weinstock-Goodman had to present with all of her extensive research, which is amazing stuff to see. But I'll give some summary of some imaging research in multiple sclerosis. All right, so we'll start out with some neuroanatomy. So like I mentioned, the central nervous system is composed of the brain and the spinal cord. And the brain can be subdivided into the cerebrum, which is this upper part of the brain, the cerebellum, which is the smaller part of the brain located in the back of the head, and then the brain stem, which is kind of the conduit between most of the brain and the spinal cord. And the brain stem itself is composed of the midbrain, the pons, and the medulla. And the cerebrum is divided into a few different lobes. So if you're reading a radiology report, you'll see mention of frontal lobe, parietal lobe, occipital lobe. And just to get oriented, this is kind of a midline slice side view of the head. And so here, this is the person's nose and mouth and chin. And then this is the back of the head here. And so the frontal lobe is aptly named and is located in the front of the head. Parietal lobe and occipital lobe are located posteriorly. And then continuing on, so the central nervous system is brain and spinal cord. So these are all MRI images of what the spinal cord looks like. And these are midline views through the spine. It's like a side view, or we call a sagittal view. And just to get oriented here, there's three different parts to the spine. We call the cervical spine, the thoracic spine, and the lumbar spine. The cervical spine is the upper part, and it's the spine that's located in the neck. The thoracic spine is the middle part, and that's we know that's it's defined where every vertebra, which the vertebrae are these individual bones which together form the spine. Every vertebra that has a rib connected to it is the thoracic spine. And then the lumbar spine is the lower back that does not have any ribs, and is a common place of back pain. We all have back pain at some point, and that's usually because of degenerative changes that happen to the lumbar spine. So on these midline images, just to get further oriented, each of these little squares is the vertebral body, which is the anterior part of the spine bone. And then back here, these Venetian blind looking things are what we call the spinous processes of the spine. And if you reach around and feel your midline back and you feel the little bumpy things in the midline back, you're touching the spinous process of the spine, which is this posterior part here. And then in the center of the spine is the spinal canal, and that contains the spinal cord, which is part of the central nervous system. And this is where demyelinating lesions can happen. And then the spinal cord is surrounded by basically water, which we call cerebrospinal fluid. And that's this bright stuff right here. So the dark thing is the spinal cord. The bright stuff is the fluid that surrounds the spinal cord. And just more kind of cartoons of what the cerebrum looks like and how we divide the cerebrum into 4 or 5 lobes. And this image down here is kind of the lateral surface of the brain. This is what it looks like. Here's the frontal, parietal, and occipital lobes, which we saw on a prior diagram. And then out laterally or to the side is the temporal lobe in blue here. All right, so the brain and the entire central nervous system, all the tissue of the central nervous system, so the brain and the spinal cord, early on was divided into two different parts by the anatomists, long before there was any CT scan or MRI scan, going back hundreds and thousands of years. The anatomists were able to see that there's parts of the brain that looked gray and parts of the brain that looked white. And so they named them very simply gray matter and white matter. And this is an axial T1 MRI image of the brain. So this is the front of the head, and these are the frontal lobes. And then in the back of the head is the occipital lobes back here. And this particular MRI, type of MRI, the names gray matter and white matter hold true to what it actually looks like. So we've got this gray part of the brain, which is the cerebral cortex and surrounds the periphery of the cerebrum. Deep to that is the white matter, which is where most multiple sclerosis lesions occur. And then deeper still in the brain are other parts of the gray matter called the deep gray nuclei. And so we see these gray parts down here in the center of the brain. So these are the basal ganglia, is another name for these, or the deep gray nuclei. So going a little more in depth about the differences between the brain's gray matter and white matter, I'm going to try to draw like a simple analogy between the brain and a computer. So in the computer, the heart of any computer is a microchip or a microprocessor, the central processing unit. So up on the right here, you can see this graphic. So this is like the microchip. And this is where all the action is in a computer. It's a bunch of switches that turn on and off. And in aggregate, when there's a bunch of switches turning on and off, it can do many calculations. And it's kind of the magic of the computer. Also in the computer are a bunch of insulated copper wires. So these are these red and black bundles right here. And these have a relatively passive role. These are just sending the electrical signals, the electrical output from the computer chip to the rest of the computer. And it's kind of a good analogy for how the brain works. So in the brain, particularly the cortical gray matter and also the deep gray nuclei, which are the two parts of the gray matter, can be likened to the microchip of the computer or the central processing unit of the computer. The neurons are the types of cells that populate the cerebral cortex, and each of those neurons is contacting hundreds and thousands of other neurons and are acting as switches. And in aggregate, when they're all working together and normally, they can do amazing things for us. So if a person decides they want to raise their hand or walk or speak, all of that happens. It all is initiated in the cortical gray matter or the cerebral cortex. The white matter of the brain, which is white on this image here, is composed of myelinated axons. And this is basically the insulated wiring of the head and the spine. And so there's not much communication between the axons. It's just these wires that are insulated, so electrical signals can be carried from one part of the gray matter to another part of the gray matter. So yeah, going more into the function of the gray matter, or the cerebral cortex, MRI can do some amazing things, and we use this clinically. So this is what we call a functional MRI or an fMRI. And with this type of MRI scan, we'll have patients sit in the scanner. We'll ask them to do different tasks while they're in the scanner, and we'll image the brain using some special techniques while they're doing those tasks. And then we'll look for different areas of the brain that light up on the images. And in this instance, we had the patient lay in the scanner and ask them, we had a screen in the scanner, it would flash a letter on the screen, and we asked the patient to think of as many words as possible that start with that letter. And as they're actively thinking, they're not vocalizing the words, they're just thinking about the words. There are very specific parts of the brain, the language parts of the brain, which light up. And so this is just one example of a task, but when there's very specific parts of the brain relegated to all different types of tasks, whether it's moving or feeling or thinking, that's a powerful tool for us. So that has to do with the cortical gray matter when we ask patients to do tasks. And then when we look at white matter with MRI using just regular MRI techniques, this is what it looks like. So this is all this white stuff right here is the cerebral white matter, and it's composed of myelinated axons. And this just looks like a homogeneous blob in here. You can't make out any differences. It all just looks like white stuff. But when we do a special type of MRI technique called diffusion tensor imaging or tractography, and we start investigating the brain with that, we see that there are very discrete wire bundles or axons that connect different parts of the brain with each other and connect the brain with the body. And here's one example of an important language pathway. These are the axons that we can see superimposed over the otherwise homogeneous mass of white matter in the brain. So delving more into the white matter of the brain, I'm trying to draw this analogy between insulated electrical copper wires and the axons of the brain. And so here's a little cartoon of a neuron, and this is the neuronal cell body, and this lives in the cerebral cortex of the brain, which is that outer part of the brain, the cortical gray matter. And it's got all these little fingers or projections, dendrites coming off of it. And those connect with a bunch of different neurons. So these are kind of all the switches, as it were, in the brain. And then it's got this long tail of, this is the axon of the neuron. And it's got this insulation around it, this myelin insulation. And here's like a photomicrograph of what an axon looks like if you cut it in half. And you can see the center part of the axon. This is where all the electrical impulses are sent through the axon. And then it's wrapped by this multi-layered myelin. So this is what the myelin looks like. Looks like there's about 6 or 8 layers there. And the myelin is this fatty substance or lipid-based substance, and it is a great electrical insulator, just as this plastic is on these copper wires that protect the conducting parts from adjacent wires. In myelin, we know that it takes, like, the myelination process really isn't complete until like the early 20s for a person. But early on in life, there are very rapid changes in myelin. So this is a brain MRI of a neonate at just a few days old. And we can see these dark areas here where the yellow arrow is pointing. This is all the white matter, but it doesn't look white yet. And that's because there's no myelin around the axons. And then when we image the same patient at 1 year of age, we can see it's changed quite drastically. What was dark is now white, and that's because there's myelin in the white matter. So there's lots of brain development that happens in the first few years, but neonates, they're relatively uncoordinated, they're not talking, and part of that is because their axons just don't have myelin around them, so their brains don't work very well, and they can't conduct electrical signals very well. And then here's an example of a person who has multiple sclerosis, and we can see these areas of focal white matter damage where there's been demyelination, and that's what a multiple sclerosis plaque appears as. All right, so when we perform a brain MRI, regardless of where you get your MRI done, there are 5 kind of basic parts to the MRI scan. They're what we call sequences, 5 different pulse sequences in the brain MRI. And those are all listed here. There's a T1, what we call a T1 sequence, a T2 sequence, flare sequence, diffusion, and this is pronounced as T2 star or gradient imaging. And each of these has different functions, and they all are important in different types of diseases. For multiple sclerosis, with current clinical care multiple sclerosis, the most important sequences that we use, the most important one is the flare image. And this is what a flare image looks like. And then the T1 weighted image, which we'll talk about a lot, is also important when patients are receiving intravenous contrast for their scans, because that's the sequence that we use to look for contrast-enhancing lesions. And then just a brief word about some more neuroanatomy. So far we've talked about how the brain is divided into white matter and gray matter. And the gray matter, there's the cerebral cortex, or the cortical gray matter, and then the deep gray nuclei as well. And then the white matter is deep to that. Well, in the center of the brain are these fluid-filled spaces called ventricles. And here we can see a great example of ventricles. It contains this cerebrospinal fluid, which is basically water. And I bring up the point of ventricles because as part of the diagnostic criteria for multiple sclerosis, we're looking for lesions that touch the ventricles or periventricular lesions. And so just so you're oriented, this is what a ventricle looks like. All right, so getting into some jargon for MRI scan, if you happen to be reading a radiology report, so most MRI images come across just as in a gray scale. There's no color associated with them. So when we're describing findings that we might see in a brain MRI, there's different words that we use. So these bright areas is a patient who has a tumor, which is this round thing, and then there's this edema or fluid in the brain around the tumor, and it looks bright. And so there's a couple of ways we can describe that. We can say that it's T2 bright. We can say it's T2 hyperintense, because this is a type of a T2 scan, or a T2 bright signal abnormality, or a couple different words we can use. And then, so hyperintensity in a report means something is bright. So most multiple sclerosis lesions, you'll see flare hyperintense is a kind of a buzzword or a keyword. And then there's the word enhancement. So enhancement, if you see that in a radiology report, that means there's a structure in the brain that when we did a T1 scan before giving intravenous contrast into the arm of a patient, and then we did the same type of T1 sequence after we gave intravenous contrast to a patient, if there's something that gets brighter on the one after we gave intravenous contrast, we call that enhancement. That's contrast enhancement. And this is a person who has a tumor in their posterior part, the back part of their left cerebral hemisphere. And we see, like, before the contrast is given, it's dark. We gave intravenous contrast, it gets much brighter. So this is an enhancing mass. So that's where we use the word enhancement. All right, so the two most important sequences for, or types of MRI scan for multiple sclerosis are going to be the flare image and the T1 image. And the flare image is so important for MS imaging just because the MS lesions show up so well. They're so conspicuous on the flare scan. And so here's an example of what a flare multiple sclerosis plaque or lesion looks like. You see it's very bright around this background of dark brain, so it's very easy for the eye to pick up. This is an example of an old plaque. So any old brain injury, whether it's for multiple sclerosis, stroke, surgery, trauma, it's always going to appear bright on flare. So flare is really handy for us as diagnosticians in radiology. Also, any acute brain injury that's going to cause edema or abnormal fluid in the brain is also going to be really bright. And so we compare the left side of this person's head. We see the cerebral cortex is quite bright here compared to the normal right side. And this is a patient who has meningitis with a bunch of inflammation of the brain surface. And then T1 is the other, in addition to the flare, the T1 is the other type of MRI sequence that's really helpful for us in multiple sclerosis imaging. It's really mostly helpful when patients are going to get their brain MRI scan with intravenous contrast, which is not all cases. Many MRI scans for multiple sclerosis are done without contrast, and there's tons of valuable information on those scans. But if we're looking for acute active demyelination, then giving intravenous contrast can be quite helpful in that setting. And so here's just another example of what an enhancing thing looks like in a brain. And this is not multiple sclerosis. This is a metastatic lung tumor that went to the brain, a brain metastasis. And we can see when we image with T1 before giving contrast, it's dark. We do the same type of T1 MRI scan after giving contrast. It gets much brighter. It's an enhancing mass. All right, just a few words about what a typical MRI scan entails. Maybe you can pick up a few different things from this. So this is what the MRI scanner looks like. It's this giant, very powerful magnet, and the magnetic field is always on. And that's why before anyone goes into this room, they're screened carefully for any metal that they might be carrying, keys or anything else in their pockets. You have to empty that. And then during the MRI scan, the person's kind of advanced into the center of the donut, and that's where the images are acquired. And then right outside of this room is where the MRI technologists hang out. And they're the folks who are running the MRI scan. They'll be talking to you like throughout the scan, telling you how things are going, checking in with you. So yeah, some tips for before the scan. So if you happen to be someone who's claustrophobic, doesn't like tight spaces, then getting some medication to help with that before your scan from your doctor can be helpful. On the day of the scan, you want to minimize the amount of metal that you're carrying in your clothes with you. And any metal that you might bring, you can put into a locker during the scan so it can be safely kept while you're in the scan. And then everyone has to fill out a screening form too, just to make sure there's no implanted metal anywhere. And then during the scan, there's loud noise and vibration, so you wear earplugs. Scans usually last between 15 and 25 minutes. Sometimes there's the option to listen to music or watch movies during the scan. With all the radio frequency energy that is going on with the scan, sometimes people feel they can warm up. And then intravenous contrast can feel cool when it is injected. And the most important thing for us as radiologists, it helps us with making sure that we're giving an accurate diagnosis, is that for patients to lay as still as possible and remain awake during the scan. Movement of the head is like the enemy of a good MRI scan. Just it gets harder to see things. And then so after the scan, the radiologist will make a report within a day or two, and then usually your neurologist or other doctor will discuss the results with you. All right, moving on to intravenous contrast, or gadolinium intravenous contrast, which is used with some multiple sclerosis brain scans. We have vast experience with using intravenous contrast. So MRI didn't really start until 1980, is when the technology was basically invented and started to be used in medicine. And we've given almost 500 million doses of contrast since then. And so we have lots of data regarding its safety. And we know in general, it's quite safe. The potential downsides of intravenous contrast or gadolinium contrast is that about 1 in every 10,000, between 1 in every 10,000 and million scans, a person can have a life-threatening allergic reaction to contrast, which is something that's not really predictable. There's an entity called nephrogenic systemic fibrosis that can happen with intravenous contrast, which is exceedingly rare. And with the new contrast material that's being used, the contrast medicine is being used, some of them, there's no reported cases of NSF. So that is a diminishing concern. And then there's been a lot of press in the last 5 to 10 years about deposition of gadolinium in the soft tissues. So usually most of the gadolinium that gets injected into the vein during the scan, the kidneys will secrete out of the body within 24 to 48 hours and it goes away. A very small fraction of the contrast will stick around in the body and can get deposited in the soft tissues of the brain and the rest of the body. And we can sometimes see evidence of this on MRI scan. So that's a potentially like disconcerting thought that there's something being left behind in your body after the contrast. But what we know is that even though we know it's being deposited, to date, there's no adverse health effects from that. It doesn't cause any problems that we're aware of. It's just a phenomenon that happens. But that phenomenon, that deposition, is much less with some types of gadolinium contrast as compared to others. So we know that these macrocyclic agents is one class of contrast that has much less deposition. And so if you're going in for a scan and you have potential concern about deposition, you can always ask your MRI technologist or radiologist what type of contrast you're going to receive during the scan. And if you can just remember macrocyclic, that's going to be the one that has less deposition. And it might be preferred. All right, so we're just going to move into more multiple sclerosis specific discussion. And yeah, just if you haven't been there, the website for the National Multiple Sclerosis Society, and I got their logo up here on the screen, is just incredibly helpful. It's such a great resource. The language that's used is very approachable. and they do a great job of explaining all the different types of multiple sclerosis. So I would point you there if you want to learn more. It's just a wealth of information. So I won't go through all the different types of multiple sclerosis. I'm going to focus on the imaging, and my time is dwindling here. But I would point you there. So the diagnostic criteria for multiple sclerosis is that there has to be neurological symptoms from a demyelinating lesion in the brain. And we want to make sure that those neurological symptoms are not happening from a cause besides demyelination, like stroke or infection. So we got to rule that out. And then the key feature of multiple sclerosis diagnosis is that there are these demyelinating lesions that are disseminated in space, meaning they're at 2 or more locations in the central nervous system, and disseminated in time, meaning that it can't just be one episode where the demyelinating lesions showed up. There have to be separated in time, 2 different time points. And historically, the diagnosis, was based on the clinical findings. Patients would come in with new reports of symptoms on physical exam, but with the advent of MRI and more advanced lab work looking at cerebrospinal fluid markers, those are now very important in the diagnosis. Let's see. So I found this chart very helpful. It's kind of a chart that shows the natural history of multiple sclerosis over decades. And just to get oriented, this green part right here is showing events of new neurological symptoms or relapses. So a person might first come to clinical attention for multiple sclerosis and have new neurological symptoms, and then those will all resolve. There'll be another episode or a relapse of multiple sclerosis symptoms, and those will mostly resolve, but there may be some persistent deficit that occurs by this offset right here. And then so there are these discrete episodes. And then as a person transitions from relapsing or remitting multiple sclerosis to secondary progressive multiple sclerosis, we'll see that there's kind of like this cumulative disability, physical disability or cognitive impairment that will occur and just on a steady rise. I include this graph because I think it's really helpful. So these little arrows down here are different demyelinating events that occur in the brain. And most of them are clinically silent. It'll be an episode of demyelination, but it occurs in the part of the brain that's not really important. It doesn't manifest with any symptoms. And we just can't see that unless we're doing MRI scans. So this is the reason why MRI is very important in monitoring multiple sclerosis progression, because a person may start a new therapy, a new drug for multiple sclerosis, and there's no episodes of new symptoms, and it seems like things are great. But we know from the natural history, there can be episodes of demyelination happening that are just what we call subclinical. There's no symptoms. And that's these arrows right here that have no associated symptoms. So this is the typical kind of progression of workup for the initial diagnosis of multiple sclerosis. A person will come in with some new neurological symptoms, not necessarily urinary symptoms or blurry vision. Those are just 2 examples. Then the neurologist will check them out and look for findings of multiple sclerosis on physical exam. An MRI will be done to look for multiple sclerosis lesions, and we can see some examples of MS lesions here. These are periventricular lesions. And you remember that the ventricles are these fluid-filled spaces in the center of the brain. They're shown as black right here. And then this is the multiple sclerosis periventricular lesion. And then here's a spinal cord lesion as well. And the diagnosis will often entail looking at the cerebral spinal fluid through a lumbar puncture procedure, where a needle's inserted into the lower part of the spine, lumbar spine, and some fluid is collected and sent for analysis. All right, so here is what typical multiple sclerosis lesions look like on MRI scan. And these are 3 images of the brain. These are FLAIR images, which are really good for looking at multiple sclerosis lesions. And then this is a T2, related to FLAIR, a T2 MRI of the spine. And we're really just looking for abnormal bright areas in the brain and at very specific locations. So there's lots of reasons why a person might have bright spots in their brain, and most of the time that's not multiple sclerosis. But with multiple sclerosis, there are very specific patterns of where the lesions occur. And so here are periventricular lesions occurring next to the ventricle. Here's a juxtacortical lesion, meaning next to the cortex or in the cortex, and that's pretty specific for multiple sclerosis. Infratentorial lesions, meaning that it's occurring in either the cerebellum or the brainstem, which you'll remember are those lower parts of the brain, and usually in the periphery of the brainstem, and then lesions in the spinal cord. And so these 4 locations, spinal cord, infratentorial lesion, juxtacortical lesion, and periventricular lesion, these are the key locations for the diagnosis of multiple sclerosis, and are more specific for multiple sclerosis. So you may see mention of those in radiology reports. And so that's what the FLAIR imaging looked like. And then remember, the other important part of the MRI scan for patients with multiple sclerosis is the T1 or T1 with contrast, intravenous contrast. And so here we can see this is a FLAIR image of a person with multiple sclerosis, and the lesions have started to just kind of merge together. So rather than there being discrete lesions, there's more just what we call confluent lesions. And so it's hard to tell here what might be new and what might be old when we're just looking at that scan in isolation. But if we were to give intravenous contrast, we can see that one of those lesions, this one right here, is enhancing with contrast. So that's a new or actively demyelinating lesion. And there's some additional clues that will cue us into a multiple sclerosis diagnosis rather than a different diagnosis. Sometimes the pattern of contrast enhancement, if you see an incomplete rim or horseshoe pattern of enhancement, this looks like a little horseshoe, that's very specific for multiple sclerosis, and you don't see that pattern with pretty much any other disease. The configuration and location of the white matter lesions is important too. This kind of looks like a finger or a thumbprint in the white matter. That's called a Dawson finger. And then sometimes we'll see a little vein going through the middle of the lesion, which is what they call the central vein sign. And then sometimes we'll see a dark rim around lesions, which is a finding that we can see with chronic active demyelinating lesions. And then additional clues to the diagnosis of multiple sclerosis on spine imaging. There's a handful of diseases that can cause these T2 bright spots in the spinal cord. They're not all multiple sclerosis caused by multiple sclerosis. But clues to multiple sclerosis is that when you see this bright lesion right here, it's a short segment of the spinal cord. It's not very longitudinally extensive. So here's a vertebral body, kind of hard to see on the screen, but this is about the size of one of the vertebral bodies. And then when we look at the spinal cord in cross section, so here this whole ellipse thing is the spinal cord. We can see that the lesion is back here, and it's only occupying a part of the cross section of the spinal cord, whereas many other diseases, there'll be abnormal bright stuff throughout the entire spinal cord. So part of the diagnosis, I'm going to move through some of this rather quickly because it's less important, but as radiologists, we want to make sure that there's not a different cause for a patient's neurological symptoms. So there's a handful of other demyelinating diseases that are not multiple sclerosis that we want to make sure they're not. This is an example of one. This is called, total mouthful, but neuromyelitis optica spectrum disorder, aquaporin 4 disease. And one of the clues that it's not multiple sclerosis on imaging, I showed you on that last slide, was that at least with this aquaporin 4 disease, when there's a spinal cord lesion, it's very longitudinally extensive. It takes up a big cross section of the spinal cord, and MS does not do that. And then another type of neuromyelitis optica spectrum disorder, this antibody disease. I'm going to breeze through that. An acute type of demyelinating disease is called ADEM, or acute disseminated encephalomyelitis. And on imaging, some of the lesions can appear kind of similar to multiple sclerosis, like this is a periventricular lesion that's T2 bright. But there's different parts of the brain involved with this disease that are less common for multiple sclerosis and more common for this ADEM disease. So these are the thalami, and that has lesions in it, which you would not see with multiple sclerosis. All right, and then there's many mimics of multiple sclerosis disease. Hey, Dr. Yadav, I think that, am I supposed to be wrapping up at 11:10?
I think we can go on because we started late, so we can definitely go on till 11:20 or more. I'm not sure how many slides we have, but
Okay. No, it's
yeah, you
perfect.
could
Thank
have
you.
extra time. Thank you.
Okay. Yeah, so making sure that, I said there's many different diseases that can cause lesions in the white matter of the central nervous system. And in making the diagnosis, we want to make sure that it's not one of these mimics. So this is a very common mimic for multiple sclerosis, is what we call small vessel ischemic disease. And as the brain ages, it's kind of part of the normal aging process to some degree. The small blood vessels that supply the brain can become diseased and they can get blocked and they cause little areas of brain injury or white matter injury. And we see examples of that in these three images here. So this is a flare image of the brain, and here are the ventricles, and there's all this T2 bright stuff, flare bright stuff next to the ventricle. But it's not multiple sclerosis. This is just an injured brain from what we call small vessel ischemic disease. And this is quite common. So it's 50 to 500 times more common than multiple sclerosis. So that's something that we're very aware of. And there are a few tricks that we can use to differentiate this disease entity from multiple sclerosis. And most of it's based on where these lesions are occurring. So here's the brainstem, or the pons is part of the brainstem, and we see T2 bright stuff in the middle of the pons. Usually with multiple sclerosis, the lesions occur at the periphery of the brainstem, so they'd be out here. But with small vessel ischemic disease, it's usually in the middle of the brainstem. And there are a few other clues we can differentiate the two. Some other mimics of multiple sclerosis. Many people who have chronic migraine will have these T2 bright spots in their frontal lobes, the white matter of their frontal lobes. And so that can sometimes be confused for multiple sclerosis. And that's where those strict diagnostic criteria that I mentioned earlier, where the lesion location is very important, comes into play, because that can help differentiate migraine-associated spots from multiple sclerosis disease. There are some normal variants. Another mouthful, ependymitis granularis. This is kind of a normal amount. You're allowed to have a little bit of T2 or flare signal around the ventricles. So that's this bright stuff right here, not multiple sclerosis. And then patients who have hydrocephalus, which is a disease where the fluid of the central nervous system gets blocked, the flow of the fluid gets blocked, and the ventricles get enlarged. So these black things are the fluid-filled spaces at the center of the brain, or the ventricles, and you can see they're quite big compared to this other patient with normal-sized ventricles. And that's because the fluid is blocked, and that can cause bright signal around the ventricles too that could potentially simulate or mimic multiple sclerosis. And then if you've had people who've had small strokes, or we'll call it infarcts in the deep part of the brain, these are called lacunar infarcts, and those can be T2 bright and potentially mimic multiple sclerosis, but we can differentiate this from multiple sclerosis because on the flare image, the center is dark. And then there's this physiologic variant called prominent perivascular spaces, which is kind of a normal fluid-filled space in the brain, and not a multiple sclerosis lesion. All right, so this slide is, I think, an important one for the kind of mission of my talk, which is to help decipher the radiology report if you happen to be looking at a radiology report. So the main things that to look for are the spots in the brain. These are called various things. They're called demyelinating plaques, MS plaques. It can be called a lesion. It can be called a focus, or a foci for plural. It can be called T2 hyperintensity, flare hyperintensity. All these things refer to the spots in the brain that happen with multiple sclerosis. And these are all relatively interchangeable terms. And then for multiple sclerosis, at least the initial diagnosis, the location of the spots is very important, because as we just saw, there's a bunch of mimics for multiple sclerosis. And so the 4 key locations are juxtacortical or cortical, periventricular, infratentorial, or spinal cord. So you, at least on the initial diagnosis report, you want to look for those, mention of those. And then the key thing that we're looking for as radiologists, and I think is the most clinically important information, in the radiology report are there any new spots in the brain compared to the last scan? If there are new spots, it could mean that there's been an episode of demyelination in between your last scan and the current scan. And not always, but potentially that could signal maybe a need to change therapy, not always. And then also looking for whether there are any like enhancing brain lesions, which you'll remember are those things that got bright after we gave intravenous contrast. And that represents active demyelinating disease or kind of an acute flare of multiple sclerosis. And then if you're wondering about the frequency with which you should be getting MRI scans, this is a very helpful resource. So these are all acronyms here: Magnums, CMSC. These are all different, very smart multiple sclerosis groups, scientists who got together, looked at all the available medical evidence about when it's most appropriate to get MRI scans, and came up with these recommendations. And you'll see that getting a scan at some point after you've started a new treatment, and then at a later interval, just to make sure that the treatment is working well, is probably the most. This kind of sets out the guidelines for when to do that scanning, and whether you should be receiving intravenous gadolinium contrast with the scan too, and whether there should be a spinal cord MRI that also goes along with the scan. And yeah, I showed this slide earlier, but just putting it in here again, just to make the point that we know that we can't always see clinically or know that a multiple sclerosis flare-up is happening, or that there's new demyelinating lesions in the brain, because many episodes of demyelination in the brain are going to manifest with no symptoms at all. You have no idea anything is going on. And so we really need the MRI to look at the brain directly and see if there's anything that's clinically silent that's happening, new episodes of demyelination that are not symptomatic. So this is what I do when I'm reviewing a scan, multiple sclerosis MRI, and just get oriented. These are flare images of the brain, looking for the bright spots. Here's a person's new scan. This is their old scan. And as a radiologist, when I'm reviewing these, I put the two scans side by side. I link them together, and I look for all the lesions. So here's a lesion right here in the right frontal white matter. I'll look over to the old scan. There's the same lesion, so I know that's not a new lesion. Don't have to be worried about that. And I just slowly and steadily march through the scan. And every time I see a lesion on the scan, I look back at the old MRI scan to see if that was there before. If it was there before, you don't really have to worry about it. There's no evidence of new disease. But we'll notice that this one lesion right here, I'm looking at the same region in the brain on the old scan, it was not there. So at some point between the two scans, there's been an episode of demyelination that may or may not have resulted in symptoms. And I just slowly march to the scan, looking back and forth between the scans, looking for any new lesion. So that's the typical review process. And then here's another patient, similar thing, where this is the new scan, this is the old scan, the flare images, and then this is the T1 with contrast image of the new scan. And just slowly move through, comparing the two scans, looking for any new lesions. And there are no new lesions there. But then when we get to the opposite side of the brain, I can see that there's this stop for me. You can see that there's a new lesion right here in the temporal lobe that was not present on an old scan. And when we look at the contrast enhanced images, we can see that that lesion is enhancing. And so that's an active new lesion. And then artificial intelligence, as I mentioned, is starting to help us in diagnosis, or has the potential to help us. And what the artificial intelligence can do, radiologists, being human, are fallible and can overlook new lesions. And so what the artificial intelligence does is it can look at a FLAIR MRI scan The computer can kind of map out where all the white matter abnormalities are. It can then look back at an old scan and compare the two and do the same thing that we try to do as radiologists and say, hey, are there any new lesions? And in this case, the computer picked up that this might be a new lesion. So this is something that we're looking to incorporate into our practice. It's an FDA approved product. It's not experimental, but we still are gaining experience with how useful this might be. And I'm going to move through some of this because I'm approaching the end. And just touching on some of the research, you saw that great talk on all the exciting research that's happening. And especially with the help of big computing and big data, we're learning more and more about how the disease progresses and the structures that are important. But I found this study to be, I thought this was interesting. So this group looked at thousands of MRI scans and looked at a bunch of different markers of scans over time. So they had many patients with many scans over time, and they looked at all these different markers, the number of T2 brain lesions, the whole brain volume or atrophy, cortical gray matter atrophy, all these different markers. And what they found, I thought was kind of interesting, is that when they looked at the cross-section of the upper spinal cord, the cervical spinal cord, and measured the cross-section of the cord, they were able to predict which patients would progress or move from relapsing remitting to secondary progressive multiple sclerosis. And they were able to predict that 4 years in advance from when they actually made the transition. So there's something about atrophy of the cervical spinal cord that can be predictive of when a patient might make that transition. And just want to emphasize that they did this by looking at hundreds or thousands of patients. And it's a very small change in the spinal cord volume. So it was just like 2% of the volume that predicted the transition, the conversion. But we can't really apply this to individual patients as of yet, because I'm not able to measure accurately, 2% volume loss in the spinal cord. We're just not that good, but this is some place where we might be going in the future. I've just got a few more slides here. So earlier in this talk, I mentioned this special type of MRI, functional MRI, where we have patients do tasks in the scanner and look at different parts of the brain and that light up with those tasks. So even when a person is just resting quietly with their eyes closed and trying to clear your mind of any thoughts, there are very discrete parts of the brain that are quite active and communicating with other parts of the brain. And it's called the resting state or default mode network. And then when we engage in specific tasks, we're moving, we're talking, the default mode network, all that activity that happens in the brain, that part shuts down and the brain refocuses its resources on doing the task at hand. And that's how the brain normally works. But what this study found is that in patients who have multiple sclerosis with some cognitive impairment, that default mode network never quiets down. It's always active. And when it should be shutting down when patients are doing, when you're doing a task, trying to talk, trying to walk, it should be shut down. But in patients with MS and cognitive impairment, it just stays active. So we don't quite know what to do with that information. And this is kind of getting my point at all this amazing research we're doing. Is like we're learning so much about multiple sclerosis and the brain. And but there's a big gap between learning about it and translating that to clinically relevant stuff where we can make changes in patients' care that are really going to improve outcomes. But it's an exciting time to be here and seeing this research, and hopefully we can make that transition. So I think I'm going to wrap up there. So just the take-home points: multiple sclerosis is an inflammatory, demyelinating, and neurodegenerative disease. MRI has a key role in diagnosing multiple sclerosis and evaluating treatment effectiveness. For your MRI scan, intravenous contrast is safe, but it's not always needed. It's not always indicated for all scans. And with the MRI report, you're looking for new lesions. Are there any enhancing lesions, or are the lesions all stable? And those are the key points. So appreciate your attention. And if you want to follow any of our OHSU groups on Instagram, we've got our handles down there. But appreciate it.
Well, thank you so much, David, for such a wonderful talk and such a nice overview for our patients. And I'm pretty sure, this will generate a lot of questions, so people would be, I think they're encouraged to ask questions in the Q&A session, which will be the last section of the talk. So we will now move on to the last speaker, Dr. Elizabeth Silverman. She is a neurologist. She is an assistant professor at OHSU, and employed also by the Portland VA healthcare system, as well as the OHSU Department of Neurology. Dr. Silverman did her medical school from Warren Alpert Medical School in Providence, Rhode Island, residency from Washington University in St. Louis in neurology, and did her fellowship from the OHSU and the Portland VA healthcare system, but with a prestigious award from the National MS Society, which is called Sylvia Lowry Physician Fellowship Award. For 3 years, and we are very happy that she joined us. She, in fact, was also awarded a very prestigious award by the VA, which is called the Career Development Award, to study the relationship between vascular risk factors and microvascular damage in MS. And I'm very pleased that she will be speaking to you all about newer things, advances in MS, and what has happened in the last few years. So, Dr. Silverman, please.
Thank you so much for that nice introduction and for the invitation to speak, Dr. Yadav. I am really excited to be speaking to all of you today. As Dr. Yadav said, I am an MS physician, and I'm also a researcher, and talking to you about the research updates is always exciting. So much research has come out over the past year, so I'll do my best to cover as much as I can. I have no financial disclosures. These are the 4 topics that I'll focus on today. The first is looking at the connection between EBV and MS. This is certainly the area that generated the most conversation and questions from my own patients, and I imagine that might be the case for many of our audience members today. I'll then talk about BTK inhibitors. This is a new class of disease-modifying therapies that is being studied. Dr. Gutman mentioned those in her presentation as well. I'll talk about where we are in research on mesenchymal stem cell transplant, and then also provide some COVID-19 updates. So let's start with EBV and MS. EBV, or Epstein-Barr virus, is a common virus. It infects over 95% of the adult population worldwide, and it can cause a number of different symptoms. The most common symptoms are shown over here on the right, and it can cause an infection known as mono. Mono itself is typically self-limited. It can cause soreness or redness of the throat, swelling of the tonsils, swollen lymph nodes, and then typically you recover fully. Sometimes EBV infection can be serious. This happens most often when a pregnant woman passes the infection to her neonate. However, when children get EBV, it is oftentimes asymptomatic. And when we talk to our own patients who may have recently found out that they're EBV positive, they may deny ever having had a serious infection in the past. Even after you recover from EBV infection, if you develop symptoms at all, the virus can cause a lifelong latent infection. And this is because EBV is unique. It has a way of evading the immune system. It lives within a type of white blood cell called memory B cells and transitions these B cells to a resting state. And what this essentially means is that the cells are sort of in suspended animation and EBV is living inside. These B cells can then move from the bone marrow into the bloodstream and across the blood-brain barrier, allowing B cells to take up residence inside of the brain. So what does any of this have to do with MS? Well, scientists have known for some time that there's a connection between MS and EBV, and one strong piece of evidence is shown here. What you're seeing up here in this top row is brain tissue from a person with MS. And down here, you have what we call the control tissue. This is tissue taken from the tonsils of somebody with mono. As I said before, mono causes some infection within the tonsils. So if you see something in this control tissue, you would expect it to be indicative of EBV. Both of these tissues have been stained for a specific type of stain for the EBV virus itself, and this specific stain turns the nucleus of the cell blue or black. So you can see these arrows here are indicating that within the brain of people with MS, there are cells that are showing EBV, just like we're seeing in the tonsils of people with mono. I should note you can see this with people who don't have MS, but it's more common with people with MS. And this caused scientists to say, why is this? What does this mean? Is there any connection? In addition to this, we've known for some time that while EBV is common in all adults, the rates are slightly higher in people with MS. So while the links between EBV and MS were suspicious, it was still not clear if EBV is necessary and sufficient to cause an MS infection. And this has been very, very hard to answer simply because EBV is so common. However, a paper was released in Science a few months ago that provided the strongest evidence to date. This study is quite unique because of its study design, so I'll spend some time outlining this. This is what's called a case control study, using a very large database of active US military personnel between 1993 and 2013. When military personnel enter active duty, they submit a blood test that's used for HIV screening, and they also submit blood samples every 6 months for the duration of their active service. So there is an enormous database of biospecimens. The authors started by looking at samples from 10 million young adults and then looked at the number of people who had been diagnosed with MS while they were in the military and found 801 people, marked here in orange. Then for every person with MS, they found a healthy control within this cohort. This is somebody who is the same age, same sex, and in the same branch of military as a person with MS. So this is what we call a matched control, and they had 1,566 healthy controls. They then took these two groups and looked backwards in time over 20 years. So looking at all of those blood samples they collected over 6 months, they said, what can we learn about these people who developed MS while they were in the service? They found a few interesting things. And the first is looking at what we call EBV seroconversion. So at the start, quote unquote, of the study, looking backwards in time, not everybody had EBV. And that's not entirely surprising. EBV infects many young adults, people in their late 20s. So perhaps this is after people entered the military service. At baseline, 7% of the healthy controls, or 107, and 4% of the people who would later go on to develop MS were EBV negative. Now, just taking those people who were EBV negative and following them forward, they found that of the healthy controls, 57% developed EBV while in the service versus 97% in the MS group. And this is a massive difference. In fact, at the end, 800 of 801 people who developed MS were EBV positive, and they ultimately found the risk of MS increased 32-fold after EBV infection. The authors were then interested in knowing what came first, MS or EBV. Now, this is very hard to answer, but as many of you likely know, patients can have symptoms of MS for years before they are actually diagnosed. The authors decided to look at a blood level called neurofilament light chain. This is something that's found in the blood that can indicate brain damage. Now, it's important to note neurofilament light chain is not specific for MS. We know that if you've had a stroke, if you've had a concussion, if you've had major head trauma, your levels of neurofilament light chain can go up. But knowing this, they looked at the levels of neurofilament light chain between our patients who ended up being diagnosed with MS and our healthy controls, and found that for those who developed MS, the levels of neurofilament light chain, or that marker of brain damage, were normal before their infection, and in fact were normal around the time of their infection, but then increased after EBV infection. In contrast, healthy controls had rates that were about the same all the way through. And this may indicate that EBV infection is occurring before brain damage and likely precedes MS-related inflammation. So, how does EBV drive multiple sclerosis related disease? Well, the truth is we don't know yet, but there are a few theories. The first is something called molecular mimicry. This is the idea that a foreign antigen or something that causes an immune response looks similar to one's own body. In this case, perhaps the EBV protein itself might be mimicking myelin protein, and the body, in thinking it's attacking EBV, is actually attacking the myelin, causing multiple sclerosis. There has been a promising recent paper that actually supports this. It was a small study published in Nature, and it showed that people with MS tend to have more mutations or changes in their EBV antibodies, and that these new antibodies actually can cross-react with a protein that's important in myelin production. So this is the exact theory of molecular mimicry driving autoimmunity that we were talking about. Even more interesting in this paper, they took these abnormal antibodies from people with MS. They gave those antibodies to an animal model with MS, and they saw worse MS in those animal models. There are a lot of differences between animals and humans, clearly, but this really led some credence to the theory that molecular mimicry may be driving some of what we see. There are also other theories. We talked about how EBV lives inside of these B cells, and perhaps this is causing these B cells to replicate in an abnormal way. We're not really sure exactly what is causing the multiple sclerosis related inflammation that we see. However, scientists are thinking about how we might be able to use some of these findings to drive clinical trials and future study. There are two clinical trials that I'll highlight. The first is a T cell treatment called EMBOLD. This is a phase 1/2 study. That means it's a very early study that's focused on safety and tolerability, but they're doing something quite interesting. They're taking donor T cells, so donor immune cells from somebody who's healthy but who's had EBV. They're taking their white blood cells and basically reprogramming them to attack EBV infected B cells, and then giving these new T cells back to somebody with MS and looking at how people do. Very, very preliminary results indicate that the treatment is safe and well tolerated, and that some people may have improvement in disability. And those with improvement may have some MRI markers of myelin repair. But again, this is very early, the study is small, and I think we'll be seeing more about this type of T cell treatment in the future. Second, the NIH is sponsoring a phase 1 trial looking at an EBV related vaccine. This is really going to be focused on people who have not had EBV infection, and I think that will mainly fall into the pediatric category. But the idea is if you could prevent kids from ever getting EBV, perhaps you could stop the autoimmunity that this virus can cause. So, in summary, EBV seems to be necessary, but certainly not sufficient to cause MS. And we need more research to understand how to best use this information to guide our management. Okay, so transitioning to BTK inhibitors. BTK inhibitors are a class of medication that we have known about for some time. The first medication in this class was used to treat a type of cancer called CML. That medication was called Gleevec. And the class of medications itself affects both the innate and the adaptive immune systems. So it's targeting B cells and the cells that break down myelin or macrophages and microglia. But one key advantage to BTK inhibitors is that they're very, very small, meaning that they have a better chance of penetrating the nervous system and getting into the brain and the spinal cord where we know that MS is causing damage. I'm going to be presenting results from a phase 2 study on a BTK inhibitor called tolebrutinib. It's a long name. It's written out here. I highlighted the phase 2 study here. So it's important to note that when we talk about clinical studies, all clinical studies move through this paradigm. We start at preclinical studies. Those are lab studies typically done in animals, perhaps cells. Move to a phase 1 study, which is a small study looking at humans, really focused on whether or not the treatment is safe. A phase 2 study is a bigger safety study, but again, focused on safety. And then phase 3 are really expanded studies where we're looking at whether or not the treatments are effective in their end goal. So this is a phase 2 study. It's a little bit early, but I think we'll be hearing a lot about BTK inhibitors in the next few years. So I wanted to provide some introduction here. The overall goal of tolobrutinib is that as a BTK inhibitor, it's going to target these B cells in a way that's hopefully more selective than medications like ocrelizumab or rituximab. The hope is that it focuses on autoreactive B cells, and that's what led to these studies being completed. This study was a 16-week, double-blind, randomized, placebo-controlled study. It was conducted across Europe and the United States, and they enrolled people between 18 and 55 years old with both relapsing and relapsing remitting multiple sclerosis, as well as relapsing secondary progressive MS and recent disease activity. So that means that all participants had had either one relapse in the past year, 2 relapses in the preceding 2 years, or one enhancing lesion in the 6-month prior to enrollment. So they're really not focusing on progressive disease, they're focusing on relapsing inflammatory disease. The main endpoint was safety, and overall, they found that the medication was safe and well tolerated. They were looking at a number of different doses. All doses were well tolerated. The most common side effects were headaches. Some patients had some elevated liver enzymes, but did not have serious sequelae from that. One patient had a serious relapse. Although it was a safety trial, they did have some efficacy endpoints. And Dr. Pedersen's talk is a really nice introduction here because what they were looking at was MRI activity. What they found is that compared to placebo, 85% of patients on the highest dose of tolobrutinib had decreases in new GAD enhancing lesions. So if you recall, those are the lesions that are showing that there's new inflammation as compared to the prior scan and happening within weeks to perhaps a month or 2 of when that scan is being completed. And 89% had decreased new or enlarging T2 lesions as compared to the placebo. We should note that they did not evaluate clinical outcomes, at least that they reported in their studies. So we don't know if it affected the timed walking, if it affected hand dexterity or disability status. But this is some initial evidence that this class of medication likely is helping with inflammation. I will highlight that this is one of several medications in this class that are currently under investigation for multiple sclerosis. You can see that this medication is also being studied for a number of other autoimmune conditions. And this is why I think we'll be hearing a lot of these studies in the next few years. One important consideration for all medications today is thinking about how BTK inhibitors may be influenced by COVID-19. So I'll highlight a few things here. BTK inhibitors, as we talked about, are really focused on B cells and not T cells. T cells are the immune cells we have that are our first line defense in fighting things like viral infections. And patients on this treatment should be able to fight viral infections adequately. However, we know that BTK inhibitors are important for B cells, and B cells are important for vaccine response. And we'll talk about this more in the COVID-19 section of this talk. But the verdict remains out on how these patients will do with vaccines. There have been a few early studies looking at older BTK inhibitors or first generation BTK inhibitors showing that they do impair antibody response. One study of 29 people on this medication found that only a quarter of them developed antibody response to a vaccine. Another found that only 1 out of 14 patients developed an antibody to a vaccine. So I think this will be important for clinicians and patients to understand and consider if and when this medication becomes available for clinical use. Interestingly, and a bit of a side note, BTK inhibitors have been under investigation for patients who do not have MS or other autoimmune diseases, but for whom they're developing severe COVID infections. This medication quiets down some of the cytokine storm or aggressive inflammation that can cause damage in severe COVID. So there are some trials looking at whether this can actually be used to help treat people who have aggressive COVID. And these results are still not yet available. So in summary, BTK inhibitors are a new class of medication that more selectively target B cells and may be beneficial in decreasing MS-related inflammation. All right, so let's transition to mesenchymal stem cells. I'm going to start by highlighting the differences between hematopoietic and mesenchymal stem cells. When we talk about stem cell transplantation in MS, sometimes these two can get confused with each other, but they're actually a bit different. Hematopoietic stem cell transplantation, or HSCT, has been studied for some time, and we have some good evidence in regards to how it acts in MS. Hematopoietic literally means that this type of stem cell is going on to generate heme, or different types of blood cells, specifically red blood cells and white blood cells. Hematopoietic stem cells are gathered from the blood or the bone marrow. And in hematopoietic stem cell transplantation, these cells are taken, they are replicated, and then given back to the patient with the hopes that they will, in theory, reboot the immune system. Basically, replace some of these autoreactive cells to give patients an immune system that isn't reacting to itself in the same way. Mesenchymal stem cells are a bit different. These cells can be derived from any number of tissues, including fat, blood, or bone marrow, and these stem cells can become any number of cells. They can become muscle cells, fat cells, bone cells, or neurons. The idea here is that if you could find a way to give patients mesenchymal stem cells, perhaps they could get into the central nervous system, find areas where neurons have died, and repair damaged tissue. In general, mesenchymal stem cells are much earlier in their study as compared to hematopoietic stem cells, but that's one of the reasons why I wanted to bring them up, to make sure that you had a chance to understand the differences between the two and understand where this research is today. So this is a study called the MESMS trial. It's the largest phase 2 trial we've seen to date of mesenchymal stem cell transplantations. In this trial, the way that they conducted their transplant is that they took mesenchymal stem cells from the bone marrow of patients and then isolated those cells, expanded them, and gave them back intravenously. So they gave them back through the venous system or into the arm, and then they followed patients out. Again, this is a phase 2 study. It was really focused on safety, but they did have some efficacy endpoints. Relatively small trial, 144 people. This was conducted over 15 sites in 9 countries, and they included both relapsing and progressive patients. Overall, their efficacy results were not impressive. They did not see any change in contrast enhancing lesions, no change in T2 lesions, no change in relapse rate, and no change in clinical outcomes. And this was looking at 28, 36, and 48 weeks after transplantation. So overall, really not seeing any clinical benefit, although the goal was that this was a safety trial, and from a safety perspective, patients did well. I think this is important to consider because this field, like I said before, is still quite early. And in contrast to the MESMS trial, there was another trial called the NEURONE trial, which did mesenchymal stem cell transplantation differently. They took stem cells out of the bone marrow and gave them back through the intrathecal space, so into the nervous system space itself, and found that in some patients with progressive disease, they may have had improvement in walking and hand dexterity. I show conflicting data mainly to say that this is where the field is. It's very, very early, and there is a lot of heterogeneity in how people are conducting these studies. So a few main takeaways. For mesenchymal stem cell transplantation, I think it's controversial at this point for progressive disease. There are some centers who are advertising performing this as a treatment. I think there's a reason it's not FDA approved. I think that this is an area where we really need more research before we're able to understand who may benefit from it. There's a lot of heterogeneity in how people are doing the treatment. That means where are they taking the stem cells from and how are they giving it to patients? And that can lead to different outcomes, and we need to look for more updates. On the flip side, hematopoietic stem cells are further along. It looks to be promising for aggressive inflammatory disease. There are some risks to the treatment, and I think that it really highlights the importance of making sure if you are considering this treatment that you're doing it in a protocolized way in a high quality phase 3 study at a center that has experience doing stem cell transplants. It is a major medical procedure, and it is best done in the hands of experienced people. I will say OHSU is a site for a phase 3 trial, which I'll talk about a little bit at the end. So, in conclusion, mesenchymal stem cell transplantation is still controversial in my eyes. Okay, let's transition to COVID-19 related updates. We have now been living for about 2 years thinking about COVID-19 and specifically how does COVID impact people with MS globally? And one of the first questions that both patients and physicians asked is, are our patients with MS doing worse with COVID? And our answer was informed by a few different studies conducted in the United States and in Europe. And what we found is that for people with MS who developed COVID, the risk of worse outcome looked very similar to people who didn't have MS. That means the people who did worse tended to be older, they tended to have cardiovascular comorbidities. Some studies found that Black race, use of walking aids, and male sex might also be independent prognostic factors to indicate worse outcome with COVID. The second question is, do our medications make things worse? The disease modifying therapies that we're using to treat MS. And what we found is that the biggest safety signals seem to come from a class of medications that affect our B cells, ocrelizumab and rituximab. In the US, we found that ocrelizumab seemed to increase the risk of hospitalization, but not death. And in France and Italy, as well as Sweden, it increased the severity of infection. And it should be noted that all of these studies were completed before we had vaccines. So this was really the early data, although many of these trends have remained as we've moved forward. So, this is information now on how people with MS may do when they receive a vaccine. Uh, Basically answering the question of, do MS patients generate an adequate response to vaccines? And this is showing data from healthy controls over here, this purple column, and MS patients over here in the orange. The MS patients, we're looking at 4 different groups: people who are not on any disease modifying therapy, people who are on cladribine, on fingolimod or Gilenya, and ocrelizumab or Ocrevus. And what we see is perhaps not surprising. Those people with MS who are not on medications are developing antibodies just like people who are healthy. And patients on cladribine also are developing good antibody responses. I should say the the y-axis here is how strong of an antibody response you're developing. So the higher the level, the stronger the antibody response. This dotted line down here is showing what is called an adequate antibody response, or expected that you would mount a response should you be infected by the virus. So untreated and cladribine patients tended to do well. On the other hand, patients on fingolimod or other S1P receptor medications had lower vaccine responses, as well as those with ocrelizumab. And the second layer of information in this image is denoted by the color of the dots. Those with red or blue dots had lower T cells, lower lymphocytes, which is expected with this medication. And it seems that the lower your counts, the worse your response to the vaccine. Ocrelizumab, on the other hand, does not affect lymphocytes. So unsurprisingly, people had normal counts, but still had suppressed responses here. So, this led to a lot of concern, and we had a lot of discussions amongst our center, nationally, internationally, and with our patients about what we should do. There is some evidence that the further out you wait from your last infusion of an anti-CD20 medication, like ocrelizumab or rituximab, the better your response might be. This on the y-axis, again, is looking at your antibody response, and this is looking at time out from your infusion. And you can almost imagine that there is a little bit of a line here, a relationship indicating that the further out you are from your infusion, the more likely you are to develop a stronger response. And the same thing is seen here, looking at a different type of protein associated with COVID-19 related vaccine. So for some patients, when it's appropriate, we were recommending that they wait longer for their infusion to get their vaccine, or at least timing it so that they have the highest possible B cell count before getting their vaccine. And one other perhaps reassuring piece of information for our patients on B cell therapies is that even though the B cells are taking a hit, the T cells are still acting. Like I said, when talking about BTK inhibitors, T cells are your first line defense against viruses, and the T cells are still generating a good response to boosters. This study is looking at patients on ocrelizumab and fingolimod and looking at their antibody levels after the second dose of their mRNA-based vaccine, before their third dose, and then after their third dose. So this is sort of looking at the impact of a booster. And what you can see is that the T cells are responding appropriately to a booster, even though we know that the antibody response is not as robust. In medications that affect the T cells, like fingolimod, the counts remain lower all around, as might be expected from this class of medication. So, I think overall, we are still learning the best way to balance treating and controlling MS and keeping people safe from COVID-19. I think overall, we still have a bit to learn, and we're learning that this is not just a disease that is affecting, overall respiratory symptoms. COVID-19 has affected every aspect of our lives. There have been studies showing that people with MS in the era of COVID-19 have increased depression and anxiety, increased isolation, and worse exercise habits. If you are somebody who really resonates with this, know that you're not alone and talk to your provider about any potential strategies that might help with this. We're fortunate actually that our patients seem to have better vaccine willingness as compared to people who don't have MS. Some people have looked at whether disease modifying therapies may contribute to breakthrough COVID infections and found that perhaps the B cell therapies are leading to increased breakthrough COVID infections, although it should be noted that the rates were very low for both of these, 2% of breakthrough infections in the ocrelizumab treated group. This data was before we had some of our more recent data about our more recent COVID variants. Finally, some people have been concerned about getting the COVID vaccine because there have been reports that COVID vaccines can lead to demyelinating events, things like Guillain-Barré. These conditions are possible, they are exceedingly rare, and the benefits of vaccines far outweigh the risk. So my take-home message to you is that vaccines are safe and effective, even if you're in a group who may not be developing as strong of an antibody response. I think that's even more reason to get vaccinated, to get boosted. And if you are to contract COVID, call your healthcare providers to see if you may qualify for any specific therapies that may ameliorate your course of COVID. Okay, so here is what we've covered so far. We've talked about how EBV is necessary but not sufficient to cause MS, and talked about the new trials that are underway. BTK inhibitors are a promising new class of medications, and we're waiting for phase 3 trials. Mesenchymal stem cells, really, we need some more data, but right now I think it's still controversial. And COVID, there's good evidence to get vaccinated and to get boosted. Now, I wanted to close by talking about a few late-breaking pieces of information. The first is the DISCO MS study, and Dr. Gutman mentioned this briefly. This was a study that has been completed, and the results are just being released in a very preliminary form. The ultimate question that the authors were trying to answer in the study is it okay for our older patients to come off of their disease modifying therapies? And this is a question that we are asked clinically every single day. The inclusion criteria for this study required that you had a diagnosis of MS, that you were over 55 years old, and that your disease was stable. That means no relapses in the past 5 years, no MRI changes in the past 3 years. And then everyone was randomized to stay on their therapy or to stop their therapy. The big take home messages so far from the data that have been released: one, relapses were very uncommon in the two groups. And two, this study was a non inferiority study, which means that the goal was to show stopping DMT is not worse than continuing. And the authors did not meet that endpoint. This is very confusing. There are a lot of double negatives in that sentence. So I'm going to take a bit of time to just go through what a non-inferiority study means, because I think that we'll be working on digesting this data when it's finally published for some time. Whenever a researcher or a group of researchers decides to conduct a study, they have to say at the beginning, how are they going to decide if their treatment was successful or not? And when they design it, they can design it in one of a few ways. One is called a non-inferiority study, and that one is shown here. And the idea of a non-inferiority study is that the two treatments, in this case, stopping your medication and continuing your medication, are about the same. This diamond indicates where the overall balance is between the two, and 0 means no change. So non-inferiority studies are really saying the two treatments are just about equal. You may say, well, I want to show that my treatment is better or superior. That means there needs to be a really big difference between the two groups and really shows that your treatment is far better than the opposite treatment. So that means that stopping medication would be far better than continuing. Or you may say, I want to show it's inferior, that continuing your medications are much better than stopping. And then you need to be way over here. The authors, I think rightly said, our goal is non-inferiority. No one would expect that coming off of your disease-modifying therapy is going to be better. And the goal was to find out if people could basically be at the 0 point. And what they found is, well, no, they were not at the 0 point. They were not over here. They were not in the inferior point. They were kind of here, the gray zone, what we call inconclusive. What this means is that people who stopped their therapy had a little bit more MRI activity, had very, very few relapses, and the results are a little bit in the gray zone. And to highlight how confusing it is to interpret the results, this is a quote that was in the lay media by the lead investigator who said, discontinuation could be inferior to continuation, but it's not clear statistically. I think the take home message from this right now, based on the preliminary results, is if you are somebody who is interested in stopping your medication, talk to your provider. Look through your past history of how active your disease has been, how many different therapies you've needed to be on, and why you want to come off of therapy. And if you and your provider decide that it's reasonable to do a trial off, make sure you get frequent MRIs and you get really close clinical evaluation. Some people will have some disease activity, but we just don't know quite yet before we see the full results if there may be subgroups that are better suited for that type of treatment. The last piece of research that I'm going to present is actually Dr. Yadav's study looking at low-fat diet for fatigue in MS. Our best clinical studies are really informed by our patients, and our patients are often telling us that they're trying different dietary strategies in order to help with MS-related symptoms. Fatigue is one of the most debilitating symptoms that our patients have. So she designed a 16-week trial looking at low-fat diet to help reduce fatigue in MS. And 39 patients completed the trial. And overall, she found that low-fat diet significantly improved fatigue compared to the control. Further analyses are still underway, and she'll be on the Q&A if you have any questions about this study, but I think it's really exciting and speaks to the type of research we really love doing at our MS Center, which are focused on treatments thinking about wellness and really being informed by the questions our patients are asking. So if you're interested in any of the OHSU-related research studies, I have some of them listed here. Dr. Yadav is completing a trial right now on MitoQ, or an antioxidant to help with fatigue. Dr. Holland is doing an advanced imaging study to look at progressive MS. Dr. Woolliscroft is doing an aerobic exercise for myelin repair. I am doing a study looking at advanced imaging techniques of the eye to understand blood vessel damage in MS. And as I mentioned before, we are a phase 3 study for the autologous hematopoietic stem cell transplant for multiple sclerosis, looking at people with aggressive MS and seeing if transplantation is better than aggressive therapies. The website for our MS Center is here. If you're interested in learning more about MS research, you can go to this website, or if you are smartphone savvy, you can scan this QR code and sign up for our registry. I'll flip through my references and leave up that QR code in case anyone is interested as we transition to Q&As. Thank you very much.
Thank you, Dr. Silverman. Awesome talk. And I'm sure it has generated a lot of questions. We are already getting quite a few questions, and there are questions where we have not addressed some of the topics that our audience is asking. So definitely we'll address them in our Q&A session. And I think I would like to now transition to Dawn so that she can explain what the next section will look like.
Thanks, Dr. Yadoff. So we're going to go ahead and take a break right before the Q&A, and we're going to actually come back at 12:30 instead of 12:10. So people have a chance to visit the exhibitors and take a break, because I know there was a lot of issues with exhibitor links during the first break, and we want to make sure people are able to visit virtual exhibits if they want. There's live representatives in almost all of the virtual exhibits. And so if you want to ask questions from, someone Biogen, Bristol Myers Squibb, Genentech, Janssen, Novartis, or National Med Society, I encourage you to visit the links. And so they are in the exhibit email, but they're also on the YouTube description. So if you look at the YouTube website and just there's a description, show more, and you'll see the links there. And we believe that we have resolved all of the issues, so you should be able to participate. And so again, we'll come back at 12:30 for the Q&A speaker panel. I also wanted to remind folks that we will be taking questions for the Q&A panel. We've received some already, which we appreciate. Thank you for all the questions we've received so far. If you have any more that have come up since the talk, please feel free to email myself at chris.ohsu.edu. And if your question is for a particular speaker, go ahead and mention that in the email, if you will, and we'll do our best to answer all the questions and get through. And again, we're going to end up starting at 12:30 instead of the initial 12:10 time. So you guys have a chance to visit exhibitors, take a break if you need to, and then we will rejoin. One more thing I want to mention really quick is the program is being recorded. I know that was some of the questions. And so you will have access to the program at a later date. Usually it's within an hour after the conclusion of the program, and you use the same link. And so if you do want to visit exhibitors and it runs over, into the Q&A section, please keep that in mind as well. And so we will look forward to seeing you at 12:30 for the Q&A. Thank you.
All right, so it's 12:30, and I don't want to take anybody here for granted or staying for long. So I would like to start right on time for the Q&A panel. I will be moderating the panel, and then we have several questions actually, which are really good to have. We and Dr. Weisstein Gutman, unfortunately, she could not really stay back, so we will try to address the question that were sort of coming from her talk. And Dr. Pedersen and Dr. Silverman are joining us for the Q&A session. So what I would like to do is I try to sort of divide these questions into categories, but I may just go back and forth between different categories. So I think what I would do is maybe start with some of the questions that Dr. Silverman, you were talking about COVID. So maybe start with those questions first, and then we can go back to other questions. So one of the questions that audience had was MS and protection against COVID. Is there any data that suggests that MS may be protecting against COVID, or is it adding any kind of added risk? Because there are some people who seem to have been, like, even though they have MS, they are vaccinated and all, and they have not gotten it yet. So maybe talk a little bit about that.
Yeah, that's a great question. I have not seen any evidence to suggest that MS in and of itself is protective, but I think that there may be a few sort of incidental things that could make it appear that way. A lot of our patients with MS are being extremely careful. They're being extremely thoughtful about who they're socializing with, and those types of behaviors can make the rates of infection or breakthrough infection less common than when we look at the general population overall. And I think that based on the vaccine hesitancy data, our patient population is likely more vaccinated than the overall population as well. And those things may contribute to that appearance. I personally haven't seen anything to suggest that MS itself is protective.
Yeah, one more thing I would like to add is there are, for interferons, for example, because they're antivirals, people who are on interferons, they may have slightly more protection, but again, it's in theory. I'm not sure we have seen the data really support that, but in theory, people who are on interferons, like Avanex or Revif or Verestron, that kind of category of products, they may have some protection against viral illnesses in general. So that's that. Another question related to COVID and vaccination is somebody's on Ocrevus and determined to be allergic to the mRNA vaccines, both Pfizer and Moderna. So, but they did get the Evusheld. So is there evidence that Evusheld is effective against the new COVID variants?
Oh, the new COVID variants. That's interesting. I think the most recent data I had seen regarding Evusheld was looking at the predominant variants that are out right now. I don't know about the latest variants, although the most recent variants are quite similar in structure to some of the more virulent variants that have been affecting people recently. Evusheld does show improvement in people being less likely to contract serious illness. And so I think one of the important distinctions is most of the trials regarding COVID-19 related either vaccines, pre-exposure prophylaxis like Evusheld, or post-exposure prophylaxis like Paxlovid are looking at severe outcomes, people ending up in the hospital, ending up on respirators and dying. Medications like Evusheld do decrease the risks of those in a way that I think is can be very promising and can be very useful on somebody, especially if you're on a medication that affects your ability to generate an adequate antibody response like Ocrevus.
And you're talking on the same topic, Ocrevus and RMS. There's another question which says that there's a patient who had his second infusion, which is like typically given every 6 months, was held off. And they did the CD20 test count, and that was undetected. And so then they were using a tailored approach of the infusion. So, so I think the question was, is it good to do that? Is it safe, or how are we managing that right now? And does it have any connection with COVID pandemic related
Yeah.
issues?
That's a great question. And I think the verdict is still out on that. I think the first question would be to know if that patient in particular has relapsing disease versus progressive disease. With relapsing disease, keeping the B cells low is important in controlling the inflammatory disease activity. With progressive disease, we don't know exactly at what point the B cells need to be in order to have disease control. I will say that more and more physicians are exploring tailored treatment algorithms for patients, looking at decreasing the dose of the infusion or perhaps spacing out the infusion for the right patients. So I think in somebody who has progressive disease, who has not had inflammation for some time, then having a tailored approach may be reasonable. We don't know the exact perfect time of the B cell cycle to give the infusion. And B cell repopulation is not a smooth linear thing. So when we check B cells, sometimes it's low, 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 and then it increases more quickly than we expect. So it's complicated. I think that we'll see some more papers in the next few years talking more about sort of a tailored approach to B cell therapies and spacing out or decreasing the doses.
Thank you. And I would just add one more thing. So yes, in our practice, at least I have been using this approach, and I have patients that have especially elderly patients, that have been able to stretch it up to 1 year. And again, as Dr. Sullivan said, progressive patients may not need as much immune suppression versus relapsing patients. So I think you have to look at every individual, and the decision should be between doctor and the patient about what the need should be for timing. All right, so Dr. President, I'm going to ask you some MRI questions. The first thing was just about the technique. So the magnetic field and radio frequency signal, is that same, different? And I think that's just a technical question, and I can go on to the other questions.
Yeah, there are a number of things happening during the MRI scan. There's a very, very strong magnetic field in the MRI scanner that's always present, whether the scan is happening or not. It's just like a magnet sitting on a table. It's always magnetic. There's always a magnetic force there. And then there are layers of different signals on top of that. So there's an additional magnetic field that is of much smaller strength that's varying during the MRI, actively during the scan. There are radio frequency signals that are happening actively throughout the MRI scan. And so they're slightly different phenomenon, but yeah.
One more question was about the contrast safety. I think you alluded to that, and you talked about the contrast that we're using for MRIs nowadays are very safe. But the question more was, should every MRI be done with contrast, and is it okay to skip the contrast? So I think maybe you can talk about that, and we can talk about what we do in the practice.
Yeah, so what we know, we follow in general the consensus guidelines on when to give contrast from these big multiple sclerosis working groups of scientists and clinicians. And receiving intravenous contrast for multiple sclerosis scan is very important at the initial workup, that very first scan. The reason why it's important is that, to establish a diagnosis of multiple sclerosis, we're looking for brain lesions disseminated in space and disseminated in time. And by giving that intravenous contrast, we could potentially meet that diagnostic criteria of disseminated in time. So if we see an enhancing multiple sclerosis lesion and a non-enhancing multiple sclerosis lesion on the same scan, we can infer that there have been two separate episodes of demyelinating disease, so it can fulfill that. And then for follow-up scans, it's in general less important, but a lot of that is just left up to, I think, the discretion of the neurologist and why it might be important in one scan or another.
And Dr. Sullivan, do you want to comment on that, what we do in practice in terms of who should get MRI contrast, the MRI with contrast?
Yeah, sure. I absolutely agree that at the time of initial diagnosis or in a patient calling with new symptoms, it's really important to get contrast. And the other thing that I'm reminded of daily is that just because you have MS does not mean you're immune to getting any other condition. So MS patients can get strokes just like somebody without MS, and being able to understand with contrast what happened acutely or what happened within the past days or weeks versus what might have happened maybe 6 or 8 months ago is very helpful. I've personally moved for routine monitoring MRIs in a patient who's clinically stable to doing those without contrast. I think for the vast majority of those patients, you can still see the changes that might have happened over the year. And if there isn't a good clinical reason for me to think that they may have happened, more recently, then I forego contrast. The other thing is that for some of our patients who struggle to stay in the scanner for a long period of time, especially if we're doing brain and spine imaging, eliminating contrast can speed it up a little bit, and then breaking up the brain and the spine imaging can also speed things up. For the radiologist, it's very helpful if patients can stay still, but for many of our patients, it's very hard to stay still because of their spasticity or claustrophobia or any of those things. So I try to be mindful of keeping the scans as short as we can, but still get the information we need.
Thank you. I think I'll take this question. So this was about the diet study that we resulted recently, and Dr. Sullivan talked about that. So the question was, what amount of fat did our patients consume on this diet? And did we look at different types of fat consumed before and during the study? And basically, I think it was about the type of fat. So what the study was designed to look at mostly limiting saturated fat. So our goal was to limit the intake of total fat by closer to 20% of the daily caloric intake, but in reality, our patients, they got down the fat to about 30% of the total caloric intake. So at baseline, when patients came into the study, their total fat intake in percentage calorie was 40%. So they did decrease significantly. They did not achieve like the 20% that we were aiming for. However, even with this significant decrease in the fat calorie intake, they did find pretty significant improvement in fatigue. Saturated fat, I said, we do have the breakdown of saturated versus unsaturated fat intake, and we will be reporting that. So I think the main decrease was in the saturated fat as a whole, but we did not really try to differentiate between polyunsaturated, unsaturated fat versus the total saturated fat. And there were other changes in the diet composition as well. Protein actually was pretty stable. Fiber intake increased quite a bit, and the complex carb also the intake that increased. So I mean, what we are seeing is decrease in fat, increase in complex carb and fiber overall. So, and plus there were very small change in the total caloric intake. So in general, the diet appeared to be very safe and people were adherent. So that's a good thing, but the fatigue improvement was quite impressive. So I think we are happy, and we will be reporting more on this data because the data is being analyzed. All right, so I think the next question I will take on would be EBV. So the question is there an easy way to test for EBV, especially like for parents whose children, like, they have parents with MS, and if the children have EBV, will that change anything, their approach?
Yeah, so EBV can be tested through a blood test. It's commercially available. It's easy to do. I think the main question is, what are we going to do with the information, given that 95% of people are positive? So I have ordered it for some of my patients who are just curious. They want to know. And I don't think that that's unreasonable. But as physicians, we always think about, well, we want to make sure that the tests that we order are going to be actionable. And right now, I don't know if the EBV data is actionable. So in somebody who is interested in whether their child has EBV, for instance, and you find out that they're EBV negative, it's very hard to know what steps you could take to prevent them from getting EBV, since EBV infection is often asymptomatic in kids, and it is one of those kind of common daycare viruses or school viruses that you may not ever be able to prevent. So it can be tested easily. I think the ultimate question is, what would we do with that information? And I think that's still unclear.
Mm-hmm. Thank you. So Dr. Patterson, one question is about significance of black holes on the MRI report.
Yeah, I think there's been some research that shows that the main marker that we're looking for on a brain MRI are the T2 or the FLAIR bright hyperintense multiple sclerosis lesions. Groups have looked at those same lesions. When you look at those lesions with a T1 weighted MRI, sometimes they look really dark and sometimes they're just like an intermediate gray. And there's a correlation between the T1 black holes, or where they're really dark on T1, that does correspond to a greater degree of damage to the myelin. So not only is the myelin degraded, but when there's a T1 black hole, the axon itself is broken, it's interrupted, and it's not being able to transmit electrical signals. So there's a greater degree of damage and associated with those black holes.
Thank you. Another question is, what do I look for to see if the ventricles are enlarging over time? This is the patient asking.
Yeah, so we have, this is one place where artificial intelligence has really helped us in diagnostic radiology, is that, during my presentation, at one point I had a new scan and a prior scan side by side, and we were scrolling through looking for the new lesions. So when we do that, the artificial intelligence is able to orient those two scans exactly at the same location in space. And when we do that, it's much easier for our eyes to perceive changes in the ventricle size, ventricle volumes. And we also have tools on our imaging review software or application that we can actually measure the size of the ventricles. And if the patient wants to do that on their own, there's definitely some free software you can download that will allow you to do that on your own scans. But yeah.
Yeah, I mean, these things are like really tough. Even in the clinical MRIs, it's very hard for us to really make sense of what to make of this atrophy or volume. And even though we have the numbers from NeuroQuant, that we have at OHSU, but I still find it very difficult clinically what to make of that at this point. Dr. I'm going to ask you this question about the general symptoms. So there's a disconnect between what the patient is experiencing as symptoms and what we see on the MRI. So the person is saying they feel that they're getting worse. MRIs are stable. There's no changes in that, but suffering, of course, is quite a bit. So the symptoms that the individual has, like painful feet and legs, and how do we manage that?
Yeah, that's a good question, and it's complicated. I think that there are a few different things to tease apart here. The first is understanding if what the patient is experiencing might be due to relapses versus progression. For many of our patients with relapsing disease who then go on to develop secondary progressive disease, they may be used to seeing changes on their MRI from when they had more relapses that would correspond with their new symptoms. Their arm went numb, they got an MRI, they saw a new lesion, their doctor saw it, and then treatment may or may not have been changed, but that was the pattern they were used to. As patients convert into secondary progressive MS, there may still be changes that are occurring in the MRI that are too hard for us to see. So perhaps there is a little bit more brain shrinkage, but for a lot of the reasons Dr. Pedersen talked about, it can be really difficult to pick those up. The brain changes all the time, and so being able to identify atrophy on a single scan is hard. And we're still working to understand how to really understand those types of factors. So it could be that the symptoms are because of progression, and that MRI is not the right tool at this point to just pick up on progression. Those symptoms often need to be followed clinically. The other thing is that with many patients who are experiencing worsening of their symptoms, it's important to dig deep into what's going on that may be affecting it. In this case, could there also be a concomitant neuropathy or something that might be damaging the nerves that could be affecting the pain? Sometimes if fatigue is worse, we'll talk about sleep patterns or perhaps mood, depression, anxiety, things that can secondarily contribute to fatigue. So it can be complicated to sort through those symptoms. But if you work with your clinician, hopefully they can help you feel better. MRIs are just not always the best tool for symptoms. Sometimes they're perfect. They have revolutionized how we think about diagnose and treat MS, but they don't show everything.
Thank you. In one more thing, so the same individual, so it looks like they're a veteran, and then because we have the MS Center of Excellence on the two coasts, and there are possibly like ways to reach out to the MS Center of Excellence doctors for sort of second opinion about certain symptoms, which the neurologist, your neurologist can actually reach out to them and see if they can offer any further guidance if there are any challenging issues going on. So that these are really valuable resources. So I will take this next one myself. This is about stopping DMT and like Dr. Gutman talked about the DISCO MS trial also, and like Dr. Sullivan, you also addressed about the stopping DMT. What is the right, age, or like what is the right scenario where one should be considering stopping DMT? Looks like there are some practices that they are saying, okay, because the DMTs were not really tested in age more than 55, so hence they should be stopped. So I don't think so that's the right approach. Yes, the DMTs were tested in patients younger than usually 60, 55 or younger. But we have used consistently in our older populations, and there are patients who can have disease activity even if they are like older than 60. So I think it is a very individual based approach that should be discussed in conjunction with your neurologist. Not just using the age as a cutoff is not the right approach. I think we need to look at the overall picture. What are other things that could be contributing towards the patient's MS disease activity, and then I think then decision made. But I think just a blanket statement of stopping DMT after age 55, I think that's not, none of us are recommending that. And Dr. Sarma, if you want to add anything more to that. Okay, thank you.
No, I agree.
So on the question on, there's another question on MRI. Dr. Patterson, you mentioned that there's a need to stay awake during MRI. I think maybe there's some confusion because you're talking about some of the functional MRIs where you need to be awake to do some task, or otherwise usually in MRI you are not really you can keep your eyes closed, you can be sedated also. So maybe you can explain that a little bit more, staying awake and needing to be sedated, that the difference.
Yeah, so for staying awake, the most important part is just staying still. And some people, when they nod off to sleep, they'll have, they call like myoclonic jerks, which is like little twitches. Other people, when they fall asleep, just in general, they may have a little bit of sleep apnea and snoring and can wiggle around. So there's a lot of variability in how much patients move when they're asleep. And so in general, if patients can stay awake for their scan and kind of remain focused on staying still, that's the best scenario. Other folks, when they fall asleep, they're completely motionless and the scan turns out perfect. So in some instances, it may be fine that patients fall asleep. And yeah, for the functional MRI studies, those aren't, they're used in the research realm for multiple sclerosis, but clinically they're not we're not doing them clinically now. So that's less important.
Thank you. There's one more question on symptoms, rather. I think it was about the osteoporosis data that Dr. Gutman presented. So regarding osteoporosis and MS, is there a recommendation regarding treatment for that? And what about the medications for bone stabilizing, like Fosamax class? So Dr. Sullivan, do you want to talk about that?
Yeah, that's a good question. I've never seen any recommendations that the threshold for testing for bone density or for starting therapies for osteoporosis are different for MS patients specifically. Patients may be in a different category if they have been on chronic long-term steroids. We know that independently is associated with increased bone thinning. I think the most important thing, though, is for MS providers and patients and PCPs to all be communicating openly about how frequently patients are falling. One of the big studies that came out of the OHSU and Portland VA group within the past, I think, 10 or 15 years is that MS patients are falling much more frequently than any of us really realized before, and patients were not reporting it to their doctors, and that in and of itself may cause your primary care doctor to want to test your bone density earlier and perhaps consider treatment. It's uncommon that MS providers are prescribing medication specifically for osteoporosis that typically is under the guise of the PCP, but it's an area where it's important that we communicate openly and think about making sure patients are on the right treatments and being open about fall risk.
I agree. Thank you. There's a question on the immune resetting, like immune system resetting or modulating. So the question was, is there research looking at helping reset or modulate the immune system? And MS has immune system being overactive. So any thoughts on that?
Yeah, that's probably where the research on hematopoietic stem cell transplant, or HSCT, comes in the most. The idea there very generally is that, you know, the patients who have MS have an autoreactive immune system, an immune system where the cells are attacking the myelin, leading to MS-related inflammation, and that perhaps by using a treatment that gets rid of the patient's immune system and then giving them back new stem cells to rebuild the immune system, that you could curb future inflammation. And so those trials are in phase 3 investigations. The data so far suggests that we're seeing the greatest benefit in people with a lot of inflammatory disease. That means aggressive MS, patients who are having a lot of relapses, which is why the clinical trial being done at OHSU, for which Dr. Yadav is an investigator, is looking at people with aggressive disease and then randomizing them to either stay on aggressive therapies that are very effective at curbing inflammation versus getting a stem cell transplant.
Thank you. And I think another thing which I would like to add, all the disease-modifying therapy that we have right now, they are targeting only one aspect of the immune system. So they're not like, you know, they're not immune suppressive in that broader term that we know immune suppressive. So, for example, B cell therapy like Ocrevus, rituximab, or Kesimpta, all of them are very targeted therapies. So they're not affecting everything in the immune system. So people are not like overly suppressed. They can still fight infection. They can still do very well. But there's a small subset of among these people who could be at high risk of infection. So there is individual biology which is different. But in general, even highly effective MS therapies, they are not necessarily immune suppressants. Dr. Person, one question was about discrepancy in, like, you know, interpreting MRIs, because there are different, as you said, like there is, you know, different individuals, radiologists or neurologists looking at same MRI, and they can have slightly different. So what does it entail? Like, you know, why can be MRIs different, and why can be discrepant in reading or interpreting?
So is the question in regard to differences in interpretation of a scan?
Yeah, why are discrepancies in interpreting MRIs? Some of the terminology that people use, CIS, some of them are saying RRMS, and so I think it's just like the neurologists are using different terminology, and maybe radiologists are using different terminology. So why is that?
A lot of it has to do with you know, maybe individuals training during radiology, and whatever was done at their institution is kind of passed on as how one learns how to do it. More and more in medicine, and particularly in radiology as well, we're always aiming for more standardization of how MRI scans are performed. Like the techniques are all the same and how they're reported. And there are guidelines on from the multiple sclerosis consortiums on how exams should be reported by the radiologist. And we're all trying to get there. And it's important for a couple of reasons, so that there's just more of a universal common language when we talk about findings on MRI scans. And then also in the research realm, and that's always a push with multiple sclerosis research or any type of imaging research, is the more standardization, the better. That way you can like pool together scans that were performed across the country or different countries, and you know, you're comparing apples to apples on these scans. But yeah, probably the interpretation stuff probably just comes down to individual training practices, and that's kind of what we learn is what we do moving forward. And it's a lot harder to change what we do rather than learn it from the beginning.
And I think same thing is true for neurologists as well, because as neurologists, when we are looking at an individual MRI or individual case, we may use different terminologies. I think that can confuse the patients. For example, like, this gentleman is saying, like, some are saying CIS, some of them are saying RRMS, they're using terminology like transverse myelitis. So these are different and different kind of terminology, but they may be explaining similar process. And then, of course, the MS diagnosis itself or the nomenclature in MS has evolved, and it has been changing over years. So I think that could also add to some confusion, because these terms like terminology like CIS, RIS, or radiologically isolated syndrome, these are very newer, I would say, the last 10-year kind of terminology. So it was not used prior to that. So it's part of like what we are learning and what we're implementing in the practice. It is evolving over time. All right, I think we are doing quite well with our questions. We may be able to finish much faster. So I will. There's a question on estriol. So we did not really touch upon the role of hormones or sex hormones in MS, but there is a lot of interest in that. So this individual is asking about the use of low-dose estriol in managing MS. So why don't we use it more often? And then, what is the state on its use right now? Dr. do you want to comment?
Yeah, I think this is an area where we're still learning. There have been some trials that have been done in the past looking at whether or not estriol may be helpful in people, I think focused on progressive MS, looking at cognitive outcomes and things like that. And we know that there's a connection between hormone status and MS. One of the most compelling pieces of evidence is the fact that the rates of relapses can change dramatically during times of pregnancy and postpartum. I think the biggest issue is that it's been hard to know who the right candidates for estriol and other estrogen-related treatments are. The animal model data looks really promising, but I haven't seen any kind of true guidance just for MS-related symptoms to indicate that estriol is appropriate for treatment. I don't know if you have any other thoughts on it, Dr. Yadav.
I personally, I have individuals who have chosen to take estriol, which we are not opposed to. The issue is like, who is the right candidate? We do not know that answer. So I usually will just tell them to talk to their gynecologist or their primary care doctor. If they feel there's a reason that they should be on estrogen supplementation, that should be fine. So I think that's the approach at least I have taken, but specifically just because they have MS diagnosis that I would use estriol, that I have not done, because I think the data is just not there yet. And I think we are almost, maybe just one last question that we have, and that was about Dr. Gutman giving that data that MS attacks decrease 17% every 5 years. She was asking to clarify the 17%, is it like of the original number of attack or 17% of the decrease attack every 5 years? So Dr. do you have any comment on that?
I wish I knew her data better. I'm not exactly sure, actually. I don't know if you have a better sense.
I mean, neither actually. So I was going to look into that myself. So I'm sorry, we can look it up, and then if you guys want to just write to us or maybe write to Dr. We can. Don, if you can just maybe get the email address of that individual, we are happy to report back, because I personally do not know the answer. So I think with that, we are pretty much done with the question and Q&A session here. And I think it's just 1:03. So Don, do you want to just come in and say if there are any more questions that came up or anything else that we want to, talk about? Don, your volume is not heard well. A little bit, it's still kind of low.
It just seems like you're kind of far from your microphone.
Oh, okay. Huh. Scoot in there. Can you hear me a little bit better now?
little bit better, but if you can maybe come closer. That
Yeah. Let me move things around. I had a keyboard in front of me. Okay. So can everyone hear me now?
Yeah.
I feel like one of those commercials, you know, those old commercials. Anyway, yeah, I just had a couple final notes before we leave. Some people had asked, and I mentioned this earlier, the program is being recorded. The live program link that everyone received when they registered and had a participant email recently during this week, that same link to the YouTube channel will turn into the recorded link for the program. So you can always go back and review the program if you like. Also, if you're on our OHSU MS Center email list, we will be sending out an email with the link next week as well, and it will be on the OHSU MS Center website. You'll be getting a survey here within the hour, and it'll be a thank you survey if you want to, or a thank you email. If you could please just take a few minutes to fill it out. It really helps us to guide the program and provide what people want to see, and it helps us just improve the program year after year. So, and we appreciate your feedback. And then regarding the drawing, I had a lot of great emails come in. A lot of people are going to be entered into the drawing. And so I will be actually selecting and notifying the drawing winners on Monday. So if you want to check back with me Monday, you can, but I will be emailing everyone who won the drawing on Monday morning. And I'll confirm that I received your email because I got a little too many to actually confirm during the program. So, which is a good sign. And also in the email that you'll receive here shortly, we had a lot of wonderful virtual exhibitors. I'll be also providing information if you want to check back in to their websites, get information, and that will be a PDF that's in the email as well.
Thanks, John. So I think with that, we will wrap up the program. And I really want to thank each and every one of you who have joined us from all around the country and from the rest of the world as well. Really want to thank our speakers who made this program so valuable, and definitely having the kind of very frank opinion and frank discussions about different topics that we knew, we did not know. I think it definitely helps all of us do a better job next time. And then want to really thank the sponsors or like the people who supported the program that Dawn mentioned. The tech support, OHSU tech support. I know there were some glitches, but I think we really thank you for running the program so smoothly despite the technical glitches that anybody can have. And then Dawn, of course, thank you to you for putting so much effort into this program, and despite having family issues and all, you still do always an excellent job. So thank you so much for your support always. So I think with that, we will wrap up, and hopefully you all like the program and definitely give frank feedback. And we will see you again next year. But in the meantime, we will have many other programs, so stay tuned. Bye, everyone.